Where's Matthew? A minute's time, we'll kick off. Off.
Ruth Hussey, non-executive.
Christine Smerser, Chief People Officer.
Claire Wilson, Finance Director for the ICB.
Gareth Priddick, Chief Executive of Whittle CVS.
Chris Douglas, Director of Nursing and Care.
Morning again, everyone. Karen Pryor, I'm the Chief Exec from Health Watch on Wirral.
Ellen Loudon, Vice Chair of the Healthcare Partnership.
Graham Irwin, Chief Executive of the ICB.
Raj Jain, Chair of the ICB.
Rowan Pritchard-Jones, Medical Director for the ICB.
Erica Morris, non-exec director.
Good morning, Mark Palethorpe. I am the NHS Place Director for St Helens and the Executive Director for Children's, Adults and Public Health in the local authority.
Good morning, I'm Claire Watson. I'm the Assistant Chief Executive at the ICB.
Good morning, Fiona Lemons, Associate Medical Director.
Good morning, everyone. My name's Adam Irvin. I'm a Primary Care Partner member.
Good morning, Tony Foy, Non-Exec Director.
Good morning, Anthony Middleton, Director of Performance and Planning.
Good morning, Anna Moore. I'm the Partner Member of the Board. I'm Chief Executive of Mersey and West Lancashire Teaching Hospitals and I'm Leader of the Acute Provider Collaborative.
Good morning, Ian Ashworth, Director of Population Health.
Good morning, I'm Laura Marsh. I'm the Place Director for Cheshire West.
Done that twice. Hello everybody, Paul Cummins, a Partner Member for Local Government on the ICB.
Thank you. We've had a number of apologies. That's John Llewellyn, Joe Rafferty, Hilary Garrett, Steve Broomhead, Louise Gittings and Neil Large. And Naomi is expected. She's had car problems, so hopefully she'll be here at some point in this meeting. So can I go to declarations of interest? I have not been notified of any interests related to the agenda today. Any declarations? No. Go to the minutes of the previous meeting. I'm looking for matters of accuracy. Fiona?
Thank you, Chair. On page 10, in the final paragraph where we were talking about NHS impact, it says that it's for trusts to embed this within primary care, which is incorrect. I will send some amended words through the directorate, if that's okay. And on page 17, the paragraph regarding Anne Marr's comments around Liverpool Women's Services Committee, I will just tidy that paragraph up as well. I'll check with Anne that she's happy that it reflects her words.
Okay. Thanks, Fiona. Ruth?
I have given Matthew a couple of corrections. I was present. I'm not listed as being present at the last.
Thank you, Ruth. So with those corrections, people happy to approve the Paul?
Just one small spelling mistake. Root cause is R-O-O-T, I believe. And I'm trying to find the one. It was in Tony's report from last time.
Thanks, Paul. So with those corrections, people happy to approve the minutes? Yeah. Okay, thank you. Can we go to the board action log? Just before we do go through the detail, I want to seek board views really on the the usefulness of the action log. We know what it means in terms of we have an action log that's supposed to keep track of significant decisions or issues that the board wants to see, again, at a subsequent meeting, or the board wants to have action happen somewhere in the organisation. And over the last year or so, we've had various ways of trying to get the action log into a place that better informs the board about that movement, about the work that we think is happening, that probably is happening, so that the board is informed. When the board asks for something, we actually find out later on that it's going to happen. Now, you can see in the action log that we've got in front of us that there are, some actions that are really old, some that are incompletely described, there's some where there aren't deadlines and timescales. I suspect there is something in the format of this paper, because a lot of people do look at it, a lot of people try and get it into a good place. So I suspect there's something in the format of this paper that doesn't enable, personal view, me, on behalf of the board, to track the significant requests that this board puts in to executives, to other teams, on matters of that it thinks it wants to be aware of and matters it thinks it wants action on. So if anybody's got any immediate thoughts about how we could improve the action log, please do shout out. If not, have a think about it. Let me have some comments, and I'll work with Matthew and Graham about proposing for March's board a different way of looking at these actions. It's really important about the effect. This is about the effectiveness of the board. Ruth?
Can I just echo how valuable an action log is? I think the key point is when making a decision to put it on the action log is that then the board expects to see follow-up and progress and an explanation if the deadline that we've agreed has passed and some corrective activity to decide whether or not it will go ahead. So I think I would strongly support the idea of having one, but it needs to be used as a tool to ensure that the board can get assurance that the things it really cares about are being followed up and actioned.
Thanks, Ruth. People comfortable with that?
Just very quickly, Rog, sorry. A very quick point. I think to kind of hone into it and make it simpler is to theme it in some way. So, as in workforce, we've talked this morning, haven't we, about the recruitment of the different multidisciplinaries and supervision, and that could come under like a workforce theme, almost to make it clearer. It was just a thought on that.
Good idea. So please do let me have your thoughts about how we can improve this. Ruth's articulated why it's so important, and it's for the significant issues that this board wants to pay attention to and wants to hear about progress on. Thank you. If we can go to the decision log, are there any comments? Ian?
It was just for accuracy, really, on that conversation. Myself and Joe have spoken about action number 58 and completed that last time around the importance of dual diagnosis and the work we're doing with the local authority directors of public health.
Okay, so is there a correction you want to make to one of the...
It was just to say that it should be closed down now, but I'm just conscious Joe's not here.
Sorry, you are talking about the action log.
Yeah.
Right. Okay. Thanks. Decision log. People comfortable with that? Okay. Thank you. So I think we're now going to the staff story. Chris, you introducing this?
Thank you, Chair. So as part of our programme of retention and staff engagement, we've been showcasing the experiences of a number of our members of staff, and hopefully when people came into the room this morning they could see that there were a number of profiles of our staff that were showing on the screen. We've talked to staff about what's their experience of working in the NHS, what motivates them to come to work, and also what we can do to make it better. But I'm delighted that Owen, who's a Commissioning Support Manager, the Co-Armed Forces Place Lead for Halton, and also Chair of our Disability and Neurodiverse Network, has agreed to share his experiences of being one of our employees with the board today. So we've filmed a very short clip for you. I'm going to hand over to Owen. Hopefully you will all be as inspired as we are by Owen's story.
My name is Owen Ashworth, and I am a Commissioning Support Officer for NHS Cheshire and Merseyside. I am also the Co-Armed Forces Place Lead for Halton and a Freedom to Speak Up Ambassador. I have worked for an NHS organisation for a decade. In April, I started with the Halton Clinical Commissioning Group, which has been merged into the Cheshire and Merseyside Integrated Care Board. I started my journey with the NHS because I was enrolled on the local college, which had a program for disabled people to get long-term work experience. Consequently, I got into the Halton Clinical Commissioning Group, creating Easy Read documents. I know that most people will be aware of what Easy Read documents are. Basically, they are used for learning difficulties or linguistic difficulties by using pictures. After my placement, I got paid employment with the Halton Clinical Commissioning Group. The reason why I chose the NHS is that I like helping people, especially those people who are disadvantaged, because there are structures that have cultural and economic reasons behind the disadvantages. These structures can be changed by simple changes like having decent homes and work, as well as being empowered in their community. The NHS can do, for example, the Cheshire and Merseyside Integrated Care Board, which is a mama community that is doing things about the social determinants of health, which I studied in university. The Disability Neurodiverse Network Meeting is a structure where disabled people can change these disadvantageous structures, which are generally based on misunderstanding about the disability or neurodiversity. I hope that the group will become a modus operandi for all staff, especially disabled staff, to make positive changes for themselves, for the organization, for the wider health and social care system, and for the community. The challenges that disabled and neurodiverse people face is separated into two spheres. The first is ableism, is the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. At its heart, ableism is rooted in the assumption that disabled people require fixing and defines people by their disability. Like racism and sexism, ableism classifies entire groups of people as less than, and includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. Secondly, different organizations' culture about the disability and neurodiversity. You are right. I am passionate about staff having a voice. I think it is important for staff to have a strong and powerful voice within the organization. It is a difficult question as the Cheshire and Merseyside Integrated Care Board is a young organization. Nonetheless, I think that the organization needs to identify where functions are located, which will help the staff make a positive change within the organization. The Disability Neurodiverse Network meeting is very new. In fact, we only had 3 meetings of the group. However, we have charter of the Disability Neurodiverse Network meeting, which is ableism, which is preeminent for the staff as it will be an opportunity to change the disadvantaged structures. Moreover, we are hoping that the Cheshire and Merseyside Integrated Care Board will be accredited as a disability confident employer. That is an arduous question. Nonetheless, I think more integration of the services, especially the Council and Cheshire and Merseyside Integrated Care Board, because the services are still departmentalised. At least they still feel like they are departmentalised to the end service user. I would like to see the centralisation and professionalisation of the social care system, which would work both the system and people.
It leaves me wanting to hear a lot more from Owen. Yeah. Good, thank you for that, Chris. I can go on to the report of the Chair. Just wanted to say just one thing really, and it's an immense thank you to the many tens of thousands of staff who, from local authorities, charitable and faith sector and the NHS, who are working in probably the most challenged part of the winter that we have, probably most challenged part of the year we have. I don't need to repeat to people in this room, we know how difficult it is, both from a cost of living crisis, the cold exacerbating issues, and the demands that are on our social and health services. And yet, when I have the opportunity to go around, to go to GP practices, community centres and hospitals, you can just see some great stuff. Despite the unrelenting year after year pressure that is on staff, it just makes you really, really proud to be somewhat associated with those staff. And when you talk to them, they are looking for solutions. They are looking for more hope to enable them to deliver the care that they really want to deliver for their patients and their service users. And when we then look at that, we look at some of the innovation that our staff, whether it's in primary care, community, mental health services, hospitals, some fantastic innovation that's happening, some fantastic problem solving that's happening to make sure that patients and service users are cared for in the best possible way. But we also know that part of the mission of the ICB is hugely important to stop the unrelenting rise year after year after year of population being more unwell than they could be, less unwell than they, get this right, being weller than they, got my words wrong. There's opportunities for us to support the well-being of our population in ways that will reduce the demands on the health and care staff across the Cheshire and Merseyside footprint. And we saw last week the award to Cheshire and Merseyside. It's called the Bronze Award for Social Value. We're the first in the country to get this award. And what it reflects is the time, the effort, focus and the ingenuity of many people across Cheshire and Merseyside who were working on the social determinants of health alongside colleagues. And we just heard Owen talk about the social determinants. I think he said that's what he studied at university. Because around this board, around an integrated care board, we know the social determinants are hugely important to us to ensuring that our populations are as well as they should be. So I was really pleased to see that Cheshire and Merseyside had attained that bronze award for social value. But when you get a chance to look at it, you'll know it's at the foothills of what we need to do, but it's optimistic. We've achieved that award. There's a lot more that we can do. And we're in Wirral. I saw some great stuff in the Community Trust, where people in the Community Trust, for example, were going out to some of the most difficult, most deprived areas, wards of the Wirral, supporting people to attain jobs in the trusts. Really great work. It's hard work to do that. And they were spending often their discretionary time supporting people in the most difficult situations to support them into good quality jobs in health and care. I saw Age UK working with GPs, working on how do we support people who are isolated in their homes, enabling them to come into warm centres, to have a cup of tea, make friends, and through that, having a direct benefit on their mental health. So there's lots of work going on, but there's more to be done. And it reminded me of the I in the ICB, the importance of integration to us. So thank you to all the staff working extraordinarily hard. Thank you to all the staff who are innovating, and well done to the teams that are leading on social value. Thank you. I'll pass over to the Chief Exec at this point.
Chair, thank you very much. Usually I talk and highlight a number of issues that we've committed to writing within the report, but I'm going to deviate from that on this occasion, if you don't mind. And I'm going to ask Ian Ashworth to kick off and talk to us. Board members may have seen through the national media that there has been a significant outbreak of measles in the West Midlands. People may or may not remember that the last time there was an outbreak of measles in Cheshire and Merseyside, I think, was 2012. So I would just like Ian to update the board as to the actions that we are taking to prepare and respond to this threat to the population's health. And this really is hot off the press.
Thanks, Graham, and good morning, everybody. You would have seen from the press, as Graham describes, the West Midlands outbreak. That's now been declared as a national incident by the UK Health Security Agency. Significant numbers of cases which are seeing outbreaks in lots of healthcare settings and educational settings. Just give a little bit of context. Decades ago, we had the outbreak in Merseyside, and we had much higher levels of MMR vaccine uptake then. The target is around 95%. It's really safe and effective. It gives best protection, 99% protection after 2 doses, 88% protection of mumps as well in there. And we had rates then around a 1-year-old 92% and 2-year-old 95%. Even then, we had over 600 cases, nearly 300 probable cases, and over 400 possible cases. That meant over 1,200 contacts were having to be followed up. We know from our colleagues in the West Midlands, they're seeing significant increases of attendance in their paediatric units and also at their primary care. And obviously that has significant impact, as well as being a very infectious disease that can cause harm to vulnerable and our children. It also has impacts on the demand of our health services and loss of school and education, etc., which goes with that as well. So what are we doing about that? Well, we convened a group with our partners last week in response to some of the calls from our colleagues at the UK Health Security Agency. Big thank you to our providers and also our local nurses, working with our directors of public health and our local authorities to look at where we can increase uptake in some of our primary care networks, our GPs where the uptake is lowest. To give an indication, our current rates are for vaccination for across Cheshire and Merseyside is about 89% for the first dose, but 79% for the second dose. But that masks some really true variation, and some of our significant lower uptakes. There's about over 10,500 individuals across Cheshire and Merseyside who aren't vaccinated, but there's some real low uptake in areas such as Liverpool, Sefton and Knowsley. So our teams there have already been really busy in trying to work with those local communities, working with our local authorities and our GPs about calling parents and carers in to encourage that vaccine uptake as well. We've also, our providers have also been cascading the infection prevention control advice that has been issued as well, thinking about the messages that we would give to people if they need to come into primary care and how you would triage them accordingly, how to respond to any outbreaks within that. We're also busy looking at how we can maximise the workforce to deal with any outbreaks or increase vaccination. We have the Live Well bus, our COVID team, which is quite innovative in Cheshire and Merseyside. They're ready to support some of our areas. You'll also see from the packs actually good examples of preventative work in St Helens, for example, on measles that have been taking place. Our local teams have been doing this already as well. But it is a challenge, and there's been a big focus on how we can really increase that work. There is a planned national call due from 1st of February to recall and support people who haven't been vaccinated as well. So that will create additional demand, but hopefully encourage people to come forward to get the vaccination. And that is one of the things that we are really pushing really now. While it's highly expected we will see cases come up the M6, etc., to our area really. So a couple of things we're meeting later on today. We're part of a wider system of public health. You have local authority directors of public health working in your local areas, working with the NHS and how to be ready for any of that and how to respond and support things like our educational settings, etc. So I will leave it there if that's okay.
Okay, thank you. And again, my understanding from what's happening in the West Midlands, they're still 4 or 5 weeks away from the peak in terms of how they are mapping this. And again, many of us won't know, but this is a really, really nasty disease with high consequences that was almost eradicated from our society. And we do have to keep pushing the message of the safety of the vaccination programme and making it available to those that have not been vaccinated. Moving on, Chair, I will just pick 3 items from the reports to highlight. Once again, I have highlighted the situation around the Junior Doctors Industrial Action, timed to take place at the most significantly busy time of the year for the NHS. As I said earlier, we absolutely respect the rights of staff to take such action, but at the same point in time, we really commend all of the other staff that stepped up, put services in place to keep our patients safe and to maintain as many services through that strike action as possible. We have declared within the board papers the number of planned procedures that had to be cancelled during that period of time. I think the problem is because we knew that the strike was coming. That's an underrepresentation of the true impact of the strike because a number of procedures were not booked for that period of time in the first instance. We know that no further strike action can take place now until there has been another ballot of the membership. But again, it is our express hope that government and the BMA get round the table and resolve this now so that we can get on with the job of recovering, reducing waiting lists. I look at the placard there in front of me and I think that's a salient reminder of the consequences of us not being able to do the level of work that any of us would like. Secondly, Chair, I just want to tell the board as a matter of record, but legally I'm not actually able to discuss it in the board, that we submitted our witness statement to the Thirlwell inquiry yesterday. That is a draft statement and again may change once the inquiry solicitors have had the chance to review and challenge any of the content of that. And we do not know yet whether the ICB will be called to give evidence when evidence starts, but that's not likely to be until the autumn of this year. And then finally, I wanted to highlight the fact that a small number of members of this board went to have a board-to-board session with colleagues from the board of the Mid-Cheshire Hospitals NHS Trust. I would describe that as a fact-finding and discovery mission because we anticipate that we will have a proposal coming to this board from the Mid-Cheshire Hospitals Trust for support for their business case for a new hospital. Now, you may say to me, well, what choice is there in this matter? Because as you're aware, the Mid-Cheshire Hospital is one of the hospitals in the country that was built with the so-called rack planks, and clearly it has to be replaced. But this is a significant investment of public money. Whilst there is obviously no doubt that the hospital has to be replaced and rebuilt, there is a process to go through. The exact size, nature, configuration of the hospital has to be determined, and it will require our support as commissioners of those services to assure ourselves that it has been designed to take into account advances in medicine, population health growth, and the way that we foresee the NHS working in future years. So I anticipate that will be coming back here as a major item in March, but just to say we have started the journey of preparing for that. As ever, myself or other colleagues will be happy to respond to any of the other matters that I have included in the Chief Exec's report, but I'll stop there.
Thanks, Graham. Any questions or comments for Graham? Claire?
Thank you. Could I just make the board aware of the issues under 6.2, that's okay, Graham, just around specialised commissioning? It details where we're up to and what we're having to do in terms of receiving the 59 services as part of the safe delegation. but also asks that board delegates authority to the Transformation Committee at its March meeting to oversee and review and sign off the documentation. It's a timing issue, surprise, surprise, in terms of our governance. So the board has delegated previously authority to the Transformation Committee to sign off earlier iterations of this documentation. So I'm just asking through yourself, Chair, if we can do that again, please, for March. Thank you.
Can I take a view on that request to have that delegation? People happy to support that delegation? Yep. Thank you. Ellen?
Congratulations, Chair and Graham, on the Bronze Award for Social Value, Item 8. We at the Healthcare Partnership had a good presentation around social value and resilience and sustainability. I guess my question is, how is this integrated with that work that we've heard about in that context?
I would suggest to you it is actually the same work. It was that team that put themselves forward for the award, and this, like a number of agendas, is perhaps new for large government-funded bodies, but to really think about social value as well as future agendas such as the Green Agenda has to increasingly occupy the heart of what we do. You know, the fact that we are committed to be an anchor institution and to use our powers as an employer and a spender of public money in our communities is fundamentally important. The fact that we also will incorporate the measurement of social value as a determining factor in any service that we have to put out to tender or for contract in the future will also underpin that, and it will start to percolate through all of the work that we do.
If I could just add something to Graham before I come back to Ruth. The Social Value Award was given because of the rigour with which this NHS Cheshire Merseyside is approaching actually turning, in fact, the rhetoric of an anchor institution into pragmatic impact on the shop floor. And it's essentially, there is a judging panel from local authorities, charitable faith sectors, trusts, the ICB, that look at the plans of each trust and say, does that look as though it's going to work? Does it look as though it's going to have any impact? I think that's what we got the award for. It takes a lot of time and effort to get that together. Trusts have to put a lot of time and effort into it, but it's coming out with some really good stuff. I sit on one of the panels, so it's pretty great. I've got Ruth and then Gareth.
Thank you for the useful report, Graham. Just a couple of questions. On the medical examiner rollout, I was curious to know how information that's gathered in that process is collated and how that will be fed into quality improvements and patient safety. What data will the ICB have at its fingertips to know what lessons are being learnt from the cases that are reviewed by the medical examiners? That's the first question. Second question was on the rollout of the enhanced access for GPs to some very specific diagnostic tests. I'd like to know when you anticipate there will be full and timely access to those tests for the GPs in Cheshire and Merseyside. It doesn't reference how long it's going to take for that full enhanced activity to be available. Thank you.
Rowan's take the first one.
Thank you. So our medical examiners, so to very briefly summarise, there is a new layer of support really to scrutinise, to professionally challenge and get behind whenever our deaths are reported. It's an independent role within our trusts already, which is very well established and is being taken further out to ultimately scrutinise all of our community and primary care deaths as well. There are well-established routes within our individual trusts that our medical examiners will report up through their quality reporting systems, through mortality and morbidity meetings, which will therefore be at individual department level. And there are already clear routes to escalate any concerns in lapses of care and deaths. Within our community, where all of this is now a relatively new setup, we've got the opportunity at place that will report through to the place quality groups, which already are there, and they themselves individually report through to our own quality and performance committee. We know with the introduction of PSERF, which is our new setup for patient safety, which is taking an interest in thematic reviews, that is potentially one of the approaches that supports us to look really carefully at this, to understand whether there are any patterns in changes that might be going on. Separately to that as well, certainly with some of our trusts that manage community services, they are already collating data on outcomes, and certainly trusts in East Cheshire now have a more sophisticated set of reporting through something called CRAB, a risk-adjusted barometer, that's allowing us to better understand exactly what's happening both with hospital deaths and those out in the community and primary care. It continues to be an evolving setup because medical examiners are still being appointed. There is a clear trajectory to make sure that we will be able to scrutinise independently every death, supporting our GPs who are writing the certificates and allowing us to respond to any quality concerns.
Thank you, Rowan. Ruth, as to your second question, we can't answer that here today. I will make sure that there is a written answer that comes back to the board next time. What I would say is the whole community diagnostic programme, we asked the acute provider collaborative to run that for us. Because whilst it's called a community diagnostic programme, it really is a diagnostic programme for diagnostic tests that used to be available in hospital, now being made available in a number of other settings. Everything that the community diagnostic programme they have done beyond our expectations, on time, and to a quicker rate than any other neighbouring healthcare system. So I will come back with a specific answer to that, but this was more to highlight the fact that as one of the many approaches to shall we say, prevent unnecessary admission and attendance at hospital, we continue to increase the number of services that are available outside of the hospital footprint. But I'll answer the specific question for you outside the meeting.
Thanks, Graham. Gareth?
Thank you. My question, sorry, it's not a question. To go back to the Bronze Award, first of all, brilliant, fantastic. I really welcome it. Thankfully, there's a couple of people around this table who know me and know that I would not normally start a conversation about money. It's normally the last place I go to. But I have to just caution that my guess is some of the organisations involved in that Bronze Award will currently be going through a process of looking at redundancies in April because of shortfalls in funding. And I'm not saying that to put the responsibility on the board. I don't believe that's the case at all. I believe it's a shared responsibility, but just to caution that and to ask whether or not the board are aware of where voluntary community faith and social enterprise sector partners are operating at the minute and what the risk is to those services collapsing.
I appreciate the difficulty that the sector has at this point in time. And interesting when you say to the extent the board are aware, one of the things I'm trying to do through Warren's office is to come and meet the chief executives of the VCS infrastructure organisations together and to do that. One of the things that I'm also particularly conscious of is that there are a number of funding streams that by nature come out and are very short term. Now you've heard Claire Watson talk earlier about the ARRS scheme in primary care. Now, rightly or wrongly, the way that money comes out from government, it comes out in one-year funding tranches. Now, we know, because one of the things that scheme can have their money spent on is things like exercise on prescription or social prescribing, that some of that money works its way into and is spent with voluntary sector infrastructure organisations. whilst that money comes out on an annualised basis, you know, almost with a degree of certainty, you know that the majority of that money will come next year or will come for a number of years. So I think part of us being more conscious of our responsibility in this social value space is to work out what assurances that we can give to partners, what help we can give them to think about employment models, and what safety nets that we could put in place for very small organisations that do engage and support the delivery of essential services. Because the other thing is, I absolutely recognise that sometimes working with a voluntary sector organisation, we will be able to reach parts of the community or society that are mistrusting of or not comfortable of accessing, you know, nationally funded corporate organisations.
Thanks, Gareth. Great question. Thanks, Graham, for the response. Really good. I think it's worthwhile saying later on the agenda we've got a proposal that comes under the constitutional item to formally establish a VCSFE rep, shouldn't say rep, person on our board as a full partner director. And that's the recognition that we're trying to cement these relationships to make sure we're far more aware and the voluntary and faith sector can influence far more the work of the ICB. Thank you for your question. I've just got one question. It's about diagnostics again. Really great to see that 10th Community Diagnostic Centre to open, and it's good to hear that we're a leading area. But there's a but. The but is we still aren't near to delivering our 6 weeks diagnostic total, and given that we're supposed to be increasing overall capacity, why?
Chair, if I could reserve that question for when we come on to the performance report later in the meeting. And Anthony was specifically going to talk about the diagnostic part of the care pathway, particularly where it relates to cancer services. So if we could return to that later in the meeting, please.
That's fine. And Anthony, if we could talk about broad diagnostics as well as cancer. Thank you. Okay, so we come to moving on. Thank you. I think we're going to the Director of Nursing and Care report. Oh, apologies, Karen, I can't see it.
Thank you, Chair. I just wanted to go back to the measles issue, if I may.
Please. Yeah.
And I recognise that things are happening to encourage the MMR vaccination, but I'm concerned about the concerns of the public and the rumours that might get out. Are there any plans to have an FAQ or some comms to manage that?
Ian?
Thank you for asking that. So there has been already this week a couple of releases. So I know our local authority directors of public health have actually all 9 across Cheshire and Merseyside are putting out a statement to encourage the importance of coming forward with a vaccination on that. I've seen that as very measured, and it's about finding the right balance of actually this is a really important thing that we've got an opportunity to make an action on now, seeing what's happening in Birmingham and Solihull. There has been comms already gone out, and we'll make sure that we can reaffirm some of that through our ICB comms and through our partner organisations. It's really important the local approaches that take place with the local communities, and we just talked about the community sector play a pivotal role in some of that, especially some of our more sort of transient population groups. People are moving around a lot, but also some of our, we live in a globalised society as well, and a lot of other communities we need to work with around that low uptake on. So it's best sometimes that those things get done locally, but in a consistent way. So we have a group of all 9 areas coming together to share some of that communications approaches, and very happy to take up a call with Healthwatch and colleagues about how we could use your networks, if that's okay.
Thanks, Ian. Thank you. Should we move on, Chris?
Yes, thank you, Chair. So the Director of Nursing report for this board is divided into 2 parts, and the first section offers a position update for the board on safeguarding activity across Cheshire and Merseyside. And then the second part provides an update on highlights, progress and achievements and plans in relation to the ICB workforce. And for that part of the report, I'll hand over to Chris Moser, our Chief People Officer, to present that section. So the report highlights a few areas, and I just want to pick up on three, if that's okay. So you'll see that the Working Together Guidance to Safeguard Children was published in December of 23. And within the paper, it highlights the main amendment within the guidance, being the addition of a new chapter focused on the importance of partnership working in the prevention of neglect or harm. There is emphasis on a shared responsibility by all agencies and focuses on the principles of working with parents, carers to offer that tailored support. You'll see that the framework also offers clear guidance for the two child death review partners, which is the local authority and the Integrated Care Board, to ensure that arrangements in place to review all deaths of children normally resident within their local area. And we are currently engaged with the statutory partners to scope a pan-Merseyside approach to partnership agreement to improve in outcomes for children. You'll also see within the report there is an outline action plan which is required by the Integrated Care Board. And the safeguarding position was presented to our System Oversight Board, which is a subcommittee of our Quality and Performance Committee. And the Quality Performance Committee will receive assurance on the delivery of the ICB statutory duties in respect of this action plan. Just to note that we've had our Associate Director of Nursing and Care with a specific remit around safeguarding, and Larry Lloyd Burns will work with public health colleagues and finance to develop modelling based on population and areas of deprivation. And we will also continue to engage fully with our partner agencies. The report goes on to highlight a section around our looked after children and care leavers, and the report defines what a looked after child is. It gives an overview of our Children in Care annual report that was presented to the Quality and Performance Committee in November, where it referenced variation in models due to their capacity and demand issues. And you'll see within the report the table around pressure points, of which is one around the delays in initial health assessments once a looked after child has been placed by a local authority. So we're working to improve the rates there. We need to have an overview of the actual numbers rather than just focusing on the percentage, so that we can quantify the unmet need and address some of the issues. But we will ensure that we feed that back through our System Oversight Board and through to provide the assurance to the Quality and Performance Committee. The section around serious violence duty, and within the guidance that I've previously focused on, there's an area around early identification of vulnerabilities and the increased risk factors of exploitation, which is clear within the document, and it places responsibilities on our local safeguarding partnerships to ensure we develop protocols for children considered to be at risk of exploitation. And the report reference about the announced joint targeted area inspection for serious violence duty within Cheshire and Merseyside, and that will evaluate the effectiveness of local multi-agency response to serious youth violence. We've developed an internal working group to ensure that we've got oversight of action from all the statutory partners. Those were the areas that I wanted to highlight around the safeguarding position, and so I'll hand over to Chris for the workforce update. Thank you.
Chris, before you go, shall we take any questions or comments from the board on the first part? Ian?
Thanks, Chris. It was just to make the board aware as well, through Chris's team and others, there were 2 police crime commissioners with 2 new serious violence duty strategies due to be published. The ICB are a partner in developing that and been informing a lot of the needs analysis as well. They'll be published in the next couple of weeks, and we'll make sure that they're on our website as part of that as well.
Thanks, Ian. Any further questions? Ruth?
Thank you. Really important issues that Chris has covered here. You referenced Table 2 and the level of delay in doing initial health assessments, and that you're going to do a review. How quickly will that review take place? Because clearly we're really letting some children down here with this level of coverage.
Yeah, I would agree, Ruth. And in respect of, there are a variety of reasons why their delay takes place. From the referral into the system and for the actual clinical practitioner and medical practitioner that currently undertakes the healthcare assessments. We will ensure that we pick that up through our System Oversight Board, and we'll take that through, and I can give a further update of how long that will take. We monitor progress on a monthly basis through the System Oversight Board, but as part of developing the review, we'll have an action plan as to how we move that forward.
Tony?
Right, thank you. Just to pick up on your reference, Chris, to in 7.5, the Children in Care Annual Report, which was very well received by the Quality Committee. It was an excellent report. And you're quite right to focus on the initial health assessment delays and the variation across Cheshire and Merseyside. I was just wondering whether we can find a place to look at the issue of children looked after in care leaves in a slightly broader context and add in information on their education attainment and their employment prospects on leaving care. So I don't find a place for that at the moment, but I think rather than looking at health assessments in isolation, it should be looked at across a slightly broader range of the basic components of getting children looked after and children in care a good start in life.
I can take that back through the System Oversight Board and feedback through Quality and Performance Committee.
Thank you.
Thanks, Tony. Thanks, Chris. Are we happy to move on? Yep. Chris? Oh, who's waving? Sorry. Paul, come on.
Thanks, Chair.
It's
No,
too big
sorry.
a room.
Sorry, it was on the last point. Those are issues that are dealt with by each corporate parenting board in each local authority. I sit as Vice Chair in Seftons. We look at all those aspects of the lives of looked after children and care leavers. And of course, health is a big part of that. We have reports at our every meeting on each aspect. I think to bring an overall report back here at some stage wouldn't be impossible, collating the experience of the 9 authorities.
Chris, your view on that? How do we incorporate?
Perhaps I can liaise outside of the board, Chair, and how we can do that through the System Oversight Group.
Okay, thank you. Thanks, Paul. Yep, are we happy to, Chris?
Thank you, Chair. So members will recall that the last Director of Nursing and Care report that came to the board focused very much on the challenges that faced our social care workforce. So today the focus is on our NHS workforce, both the ICB as an employer, but then also the staff that work across our NHS providers. So looking firstly at the ICB as an employer, as you know, on the 1st of July 2022, we brought together 9 organisations, all with very different cultures, very different behaviours, and very different approaches. And during our first year, we focused very much about how we engage with staff, how we improve the staff experience. And we've developed what we call our Staff Engagement Forum, who have worked with us very closely to develop a range of plans. And on page 56 of your pack, you'll see there the 5 key areas that we've focused on in terms of our staff experience improvement programme. And that's very much been based on the feedback that we've had from all of our staff. At the end of last year, the ICB ran its 2nd national staff survey. And I'm delighted that 3/4 of our staff took the opportunity to feedback on what it's like to work in the ICB. And this will give us a really robust platform now to make some improvements. The results from the staff survey are embargoed until the spring, in line with all NHS organisations, but based on some very early feedback that we've had, our Staff Engagement Forum and our people team have started to make some plans. They've been out and talked to managers about what the feedback in their teams is looking like. It's really important that the staff have worked with us to develop a range of campaigns to raise awareness, to focus on staff health and well-being, and we've celebrated a number of national events, including Black History Month, Disability History Month, and we look forward to the LGBTQ History Month. We've now established 7 staff networks, which have all got an executive director as a sponsor, and whilst it's still very early days, as you heard from Owen this morning, those networks are now becoming quite established and having a real impact. And I think it was really powerful this morning that Owen could describe what he saw as the future purpose of those. We've established a people committee to consider the workforce issues internally, and we now have a monthly dashboard that we take the people committee through, and I also take that through to our executive team meetings. And whilst it's very detailed, I'm just going to share with you a couple of the slides so that you can get an indication. I promise I won't take you through them all. I was told if I click there we go. So we start off with our main dashboard, which as you can see has got a huge amount of information on there, but it looks at our staff in post month on month. So any member of our staff or our leadership team, etc., can see how our staff is increasing or decreasing month on month. It looks at things like our compliance with appraisals, with statutory and mandatory training. It looks at how any changes in staff is impacting on our things like our disability and our BAME percentages. So I appreciate there's a lot of information on there. It's difficult for you to see, but I think that really gives our staff and our managers something to really work on. It also dispels some rumours as well. Very often we'll hear things like the ICB is hemorrhaging staff, and clearly based on that we're not. So if I move on then, we also drill down on each of those metrics. So you've got here a slide which gives you a little bit more detail in terms of sickness, employee relations. So at a glance our staff can see how many grievances we've got, how many of our staff are on long-term or short-term sickness, and it helps us to manage that across the organisation. We also detail for managers any organisational changes that are going on. So again, there is that awareness of things like consultation, be that on management of change programmes where we're looking to change structures, change people's bases, and also where we're bringing staff in or transferring staff out. So you'll see that there. So we detail that on a monthly basis so people can understand why our staff has increased or decreased based on those changes. And then finally, we always look at some of the topical areas. So here's our staff survey journey. So it takes you through from when we receive our results, how we're going to engage with staff, how we're going to engage with managers, how we develop our plans. So at any point, managers can answer staff questions about how we're going to deal with that. So I'm just going to move on now to our role as a system convener across our system, and the ICB has got a number of nationally mandated responsibilities, and these are delivered in partnership with all of our providers. So today I just wanted to share with you some of the work that we've been focusing on across Cheshire and Merseyside. Back in 2021 there was a national report which was entitled The Future of NHS HR and OD, and that outlined the strategy for us as a profession, but also how we started to make a really positive impact in terms of the experience of all of the staff that work across the NHS. So it's about how we deliver services, how we make sure that we use the best technology, and how we actually understand what staff are looking for from our service. And it's really important now to say that because of things like the increase in retirement age, we can now have up to 5 generations working together across the NHS. They all have different expectations of work, how they'll be managed, what those contracts will look like. So it's really important that the people profession equally updates itself. One of the areas in that report was about scaling people services, looking at what we do, how we do it, and how we can improve our processes, how we can streamline what we do, remove duplication, and make it easier for staff to move across the NHS. And so we've been doing quite a lot of work around that. So you'll recall as well in the summer of last year, we saw the publication of the long-term workforce plan. That had 3 priorities around train, retain and reform. There is not a huge amount of work that I can update you on that at the moment. At the moment, most of the work is happening with our education providers, and I think Rowan referred earlier to the fact that some of our education providers are now looking at how they can scale up the number of places that they can offer. At this point, the NHS is asked to look at how we can increase clinical placement capacity, because that is a really important component of any clinical training. The paper makes reference to some of our system dashboards, and I'm just going to share with you some of the data that we share on a monthly basis with every one of our trusts, so that we can start to triangulate workforce with activity and with finance, but also give you an indication about how we work collectively to monitor some of these issues. And again, I'm just going to share with you a few slides, because it is quite a big pack that we send out. So first of all, we look at our staffing levels month on month. We identify any changes, whether that be positive or negative. And this slide just shows our substantive staff, so those who are not working on bank or agency contracts. And we plot that, and it's very difficult to see on that large screen, but we look at the trends on that as well. So you can see which trusts have increased the numbers, which trusts have gone down. We then also look at what our bank spend is, and on this we look at how many staff we've used on banks, how much it costs, what's the percentage of our total pay bill that we spend on bank and agency, and then we do a similar report in terms of our agency staff. I'm really delighted that in Cheshire and Mersey this year we've seen a significant reduction in the amount of agency staff that have been used. And just to summarise for you, because I recognise it is hard to see on there, this year our substantive staff has increased, our bank use has reduced slightly, but we've also seen quite a significant reduction in our agency costs. We also look at our vacancies, so we plot that trust by trust, and again look at our any trends that might be in there, and we also start to look at why we've got vacancies in some trusts and not in others. And we look at where the vacancies are, so whilst there you have the totality of vacancies across trusts, we can drill this down into particular staff groups, which is really important when we're doing that work across the different organisations. So when we triangulate all of this data, it allows us to see what the capacity is that exists in staff. So that, again, we look at how many staff have we got, what bank and agency we're using, what is the turnover, how many vacancies, what's our staff sickness like, and that gives us that picture of how many staff we've actually got available to deliver frontline patient care. So this information also helps us to develop really robust workforce plans, which in turn then helps us to commission the right number of training places going forward. So while today's focus was very much about our NHS workforce, I think it would be remiss of me not to bring to your attention the publication of a really important document which focuses on our social care workforce. So the annual Skills for Care, it's called the State of Adult Social Care Sector and Workforce in England report, which was published back in October of last year. This gives a huge amount of information about what's happening right down to a local authority borough level in terms of pay rates, turnover, attrition rates, what the ethnicity makeup of particular boroughs for social care is. We work really closely with Skills for Care to make sure that our plans don't compromise those that go on in social care. But I would recommend that report. It's really, really detailed. So I appreciate there's a lot of information both in the written report and on screen today, but I suppose I'll stop there, Chair, and happy to take any questions.
Thanks, Chris. Can I take any questions or comments on this? Warren?
Thank you, Chair. Apologies for being late this morning as well. Thank you, Chris. It's really valuable. I suppose where we're getting into, we're seeing that demand is going to increase substantially over the next 4 or 5 years on health and care. And I suppose it's thinking through, we've got the kind of ICB staff workforce, we've got the social care workforce, and we've recently published the state of the sector for Cheshire and Merseyside, where there's 36,000 staff working in the voluntary sector and 1/3 volunteers. I suppose what we're not seeing is, well, what I'm not seeing in today's report, it's not to say it's not in the thinking, is what the thinking is over the next 3-4 years about how we support the health and care workforce in that kind of more coherent way across those 3 sectors. And I suppose it's seeing how that might operate. So is there something around an ethos around one workforce across the piece? Is there something around training, around new models of working, around population health prevention, early intervention? And I suppose there needs to be, really importantly, a kind of a programme around culture of working and integrated working that we need to see coming through in this strategy. Otherwise, we will not be able to meet the demands that we will face in just 2, 3, 4 years' time. So it was whether that thinking was in play. Yeah, Chris.
Yeah, thank you, Oren. So yeah, absolutely is in play, and as you know, we've now got 2 of your colleagues sitting on our Cheshire and Mersey People Board, and at a meeting yesterday we're proposing that we actually have a voluntary sector subcommittee now of the People Board, which will work up that voluntary sector social care workforce strategy that's aligned then to the wider Cheshire and Mersey one.
Brilliant, thank you.
Thank you. Any other questions?
It's just around freedom to speak up, and I know the ladies are with us at the moment. We've got a whole session on that, and as the sort of NED support for freedom to speak up, I'm seeing all this data, which is obviously really rich and it informs us. Are we picking up kind of the look and the feel as well? Is there something, and it's kind of thrown out to all the board really, as we're working through these papers, is there something about freedom to speak up that we should be picking up wider, broader? Thank you, Chris. Sorry, it's a bit of a wide question, but...
No, thank you. We're fortunate today that Vicky's here to do an update in terms of freedom to speak up later. But I think it's really important, isn't it? We'll have 2 reports later, one from Thomasina around equality and diversity and one from Vicky on freedom to speak up. And they are lenses that I think we need to constantly be looking through when we look at every decision and every paper that we consider at this group, because there will be themes that perhaps we pick up as a consequence of one report, and what we're trying to do is make sure we don't just rely on the staff survey, for example, to give us our data, but we actually look at informal contact, what's our staff engagement forum telling us. So it is about collecting information from lots of different sources. And I think as you'll hear from Vicky later, the freedom to speak up is not just limited to us as an organisation. So we get lots of people refer issues to us from primary care, from other providers. So we are starting to build that richness, but it's still quite early days.
Okay, thank you. Any other questions? Chris, just a couple from me. One is just looking specifically at the ICB workforce, and we saw some data flashed up there. And I'm fully aware that that information has been discussed in the subcommittee around workforce. That's great. I do think that this board needs to discharge its responsibilities both to how productive and also how well looked after our staff are directly as well. So I think we need to see at least an annual report here around the ICB staff, including the staff survey results. Perhaps that's a May thing, looking at the rich picture that we see. The other one is a question about the system workforce board. I think it's been quite some time since we've seen any sort of strategic direction around that. I think we need to see that, given the criticality of it and also the link with finances, because some of those growth figures that you see, it's inconsistent with what we think our financial pictures should be. So I think we need to see an integrated approach to the system level workforce plan here, looking to you to determine when that needs to be. Give us a clue when you think that could happen.
So the next Cheshire and Mersey People Board is on the 20th of February, okay. So we could bring something back through to the March.
March, okay, that'd be good. Yeah. Okay, thank you. Are you happy to move on to finance report, Claire?
Yes, thank you, Chair. So there's quite a lot been going on since we last met formally as the board, so I just want to draw your attention to a couple of things in the paper to clarify where we are. So there's probably 4 things that I want to pull out. I want to tell you a little bit about the financial reset that we did mid-year, which I did raise when we last met, but I've got more detail now, so I describe that to you. Secondly, I'll just touch upon where we are at month 9, so at the end of December, which the report describes, but I'll just sort of summarise that. I want to draw your attention to the current forecast that we have as a system and as an ICB, and the risks associated with that, because it is still a highly risky position. And then finally, some very brief words about the work that we're doing to plan for next year. So there's a lot going on at the moment in finance, so apologies for the level of information I'm presenting today, but hopefully the report is self-explanatory, but I do want to, as I say, pull out some things. So we have done a reset of the position in conjunction with national colleagues before Christmas, which essentially was around us receiving a national allocation to support the costs for industrial action and other pressures that the NHS was experiencing in year. So we've received that money. We got £41 million from them. And in addition to that, we got some flexibility in the way that we have to deliver on our elective recovery so that we get effectively our income for elective recovery protected in recognition of the fact that we aren't able to do as much elective work given those industrial action events. So altogether, those things enabled us to get in around about an extra £55 million. In addition to that, at the same time, we had conversations with NHS England around the in-year costs of the new hospital in Liverpool, and we had successfully, they agreed to fund us £51 million in recognition of that. It's a non-recurrent value, and it was predicated on the work that we were doing during the reset, and there was an expectation that we would use that funding then to eradicate our planned deficit, which was 51 million, and aim now for a break-even position this year. So that's all outlined in the paper, but I just did want to draw your attention to that we've now moved from targeting a deficit plan as a system to targeting a break-even plan as a system. And some of those pressures that we were experiencing that I've talked about before have been partially mitigated through the additional funding that we've received. However, there is still a significant level of risk and challenge in delivering that this year. When we did the reset, that was on the basis that there would be no further industrial action during December and January. That was the assumption that we were all asked to make in our modelling, and clearly that has now not been the case. So we are required now, when we report our position, to describe how we're doing against those original assumptions and what the financial impact is of the industrial action and what impact that might have on our forecast. So that's the reset. I'll move on then to month 9. So this report presents the December position, and you'll see here that there's a chart 1 on page 3 that shows the improvement in the position between month 8 and month 9 as a sort of an uptick in our in the red line, and essentially that's the money that I've just described coming into the system and playing into that year-to-date position, both in terms of the industrial action income but also the new royal income. So very much having a positive impact on our cash position and our financial position, but still a long way to go between now and the end of the year. And you'll see from the table 1 on the same page that we are at the moment showing that we are £40 million away from where we'd expected to be at this point in time, even with that additional funding. And that is 2 reasons. One is the risks associated with the delivery of the plan that are still not being mitigated in full, and secondly, the impact of that additional industrial action in December and January. So we're showing within our report the impact of our financial position both with the impact of industrial action and without it, so that we can see how we're performing against our original expectations during the reset and how that additional industrial action is having an impact on the position between now and the end of the year. So you can see that as it stands at the moment, we are now formally forecasting that we will be £21 million away from our plan, our break-even plan, by the end of the year, given the impact of December and January's industrial action, which we have no funding cover for. So that is now part of our formal forecast. However, in addition to that, there are still a series of risks in order for us to address before the end of the year. So that's month 9, and you'll see from there's lots of detail in the paper. We've got place level analysis in the appendix. We've got analysis of providers' positions. We've got analysis of the ICB position. I think for the ICB, and just something we've talked about at this board before, the cost of continuing healthcare and mental health packages of care for us are our biggest financial pressure and are significantly overspending. And in the year to date, you know, that figure is £45 million for those two things together that we are overspending by. So that's spending more than we planned to at the beginning of the year. And there's lots of work going on at place level to address that and to make sure that the care being received by patients and our populations is appropriate. So, second thing then is, third thing then is the impact on our forecast. So I've described the industrial action and I've described some of the risks that we are still managing. We discussed some of those risks at Finance Committee and in particular some of the place financial positions, the budgets and the overspends at place, and I'm sure Erica will describe some of the things we talked about at Finance Committee, but that is something they're very much keen to get additional assurance on in the work that we're doing internally to address that. As it stands at the moment, we've still got £38 million worth of uncovered risk within the ICB position. So I just want to make sure the board is absolutely, recognising that. And then finally, it's that time of year where we are now starting, we've already started, all the work that we need to do to plan for next year. We are aware of lots and lots of the financial context that we'll be operating in next year. The ICBs were all given a 2-year allocation, of which next year is the second year. We are expecting some adjustments to that, potentially given the levels of inflation that we're now experiencing compared to what we'd expected 2 years ago. But having said that, in the main, we know lots of the variables that we need to know in order to start that work. So we're getting on with the planning. The final guidance from NHS England isn't yet out. We don't quite know. We expect to be able to submit plans by the end of February and again at the end of March, but the final dates for that will only be confirmed when the guidance is out. But the level of non-recurrent CIP that we are delivering this year means that our financial position that we are looking at has a lot of non-recurrent measures within it. And so as we go into next year, we're taking an exit run rate of some, really big financial challenges that we are, very mindful of and working with partners to address. So I'm going to leave it there and open up to questions. There's clearly a lot of information in this report.
Thanks, Claire. So perhaps if we just focus in on our end of year position initially. So, people, any questions or comments? Nope. I have. Somebody say? Oh, Tony.
Yeah. Thanks, Claire. I think the paragraph you've set out in 2.7, the unmitigated risk is what caught my attention. You quite rightly pointed out again to us that a lot of this relates to continuing healthcare, and also you've added in efficiency risks in some providers. So I could ask two very brief questions. We're working towards changing the operating model for continuing healthcare in place, and is this an opportunity for us to, at the same time, to look at the financial pressures and see whether there's some way of monitoring finances better, working it into a different operating model for assessing continuing healthcare? Because later on in my report, you'll see there's a considerable variance in the delays to assessments, which indicates probably capacity issues or demand pressures there. So would it be helpful to bring the two together?
Yeah, absolutely. And I think the two definitely go hand in hand. I think one of the difficulties we've got with the operating model as it stands with 9 separate systems effectively is being able to do some of the really robust reporting that we'd like to do, which we will be able to do once we've got a single approach across the system with that consistency and single sort of business intelligence, if you like, across the whole piece. So that is very much something that we will see improved as we work through the new operating model. But then in addition to that, as you quite rightly say, some of the delays in those and the capacity is also an issue for us, which would be an issue under any operating model, and is something we're addressing through, bringing in some additional support, really looking at where we can increase our capacity to do the patient reviews that we need to do. So, and colleagues around the table will have even more information on where we're up to on that. But yeah, I agree with you. It goes hand in hand.
Yeah, thank you. There's just a very brief, the second point you've pointed out to efficiency risks in a handful of providers, and you've gone through a few of those later on. It's just, have you got a view as to the extent to which trusts are relying on non-recurrent, non-pay options to bring about balance in their position, and does that indicate greater pressures building up in next financial year?
Yes, so when we set the plan, we were really, all partners, including ourselves, but all of our providers, were really clear about the level of non-recurrent assumptions within those plans. So, and we report our cost improvement programmes. In this report, you'll see in the appendix, when we look at the delivery of cost improvement, how much of that is recurrent and how much is non-recurrent. So we separately identified it in the plans. We're monitoring it in year separately as well. We're tracking it in that chart 1 that you'll see on page 6. You can see the position separated out, including and excluding those non-recurrent measures. But the other piece of work that we did was quite a detailed piece of work with all partners in the system, or provider partners in the system, around the exit run rate. So any impact on income or expenditure that is non-recurrent, and you know, the exit run rate going into next year for each provider, given what we know is being delivered this year. And you know, that does point to a significant challenge into next year.
Thank you, Tony. Erica?
Over to me. It's for me, as the Chair of Finance Committee, to give you the reassurance. You can see the quality of the data, and we do deep dive. I mean, we are in a position now, we've had the reset position, and we need to balance. So the priorities, and I wanted to thank Anne on behalf of all the collaboratives, our real priorities now are getting the providers with their boards to do as they want to do, and to bring it in as close to plan, or on plan is probably the appropriate wording. The efficiencies that we moved more to recurring that we can than non-recurrent. And the third one, I'm sitting next to a place director, is all around the place budgets. So we have a deep dive in March where we're going to go into the recovery plans with some of the place directors as well. So it is a team event, and we are doing this forensically when we all meet together. So it was to say thank you to the places, thank you to the collaboratives and all the providers, because, you know, we've really got to do everything we possibly can to get to that position this year. So on that, the only alert that I had was the change in provider selection regime, so all very exciting. The interesting thing is it came in January, so we talked through the risks. So this was presented to us to take action. I think it was presented to us in December and took action in January. So it's to give you the reassurance that we have the team and the support and the intelligence behind it to move forward with this. But there are risks around that. There's no run-in period. There's transparency on everything above £1 now. So we've got to be very open, transparent. We've got to have data systems that are recording all of that, and that has to be from now. And also there is pressure on our workforce in the short term, because there's lots of change. The good news is the longer term that will ease off, and there will be definite benefits of this new regime. But it does pose issues at the very beginning that we will handle. So I think that's it from me on that one. I'm going to be like Mr. Ben today, because I'm 3 chairs. So that's my age, isn't it, Mr. Ben?
Thanks, Erica.
Thank you.
And so Erica has jumped an agenda item, so that's okay. It's good, it's relevant. On the finance report, I just want to come back and building on what Erica's just said, I can see we've got assurance on the provider sector financial controls and their progress, albeit it's risky. I can see that we've got, you know, good, robust assurance around what's happening. It's less so for CHCs. I'm really hearing we've got reassurance and some assertions. Okay, perhaps a question for you. I don't see in the notes from from the Finance Committee the deep dives that probably are happening around CHC. I've not looked at the committee papers, so it could well be there, but it's not in the highlight report.
Yeah,
So
sure.
given that this is one of our most significant ICB issues, could really need to understand that better.
The deep dive was done, I'm just thinking it was 2 FRCs back originally when all the challenges were put on the table. Since then, we've actually recruited support because it is so important. And that is working through its stages now. I mean, Claire's obviously got more detail than myself, but we are sitting, because I think we're all questioning how quick can we make this change. And I do know that Claire, I mean, you told us in the Finance Committee, there are some highlights straight away, isn't it? It's challenging because the whole care market is challenging, but there are some highlights, aren't there, straight away from the
Okay, I can see Claire Watson just waving at me on this one, Claire. So I'm looking for assurance about key milestone steps that have been taken to control.
Okay.
Claire?
Yeah, sorry. Thank you. I think there are two pieces of work really here. One that Chris is leading, Chris Douglas, in terms of, I suppose, the reorganisation of the service in the in-housing. So we will have, from April, a single model across Cheshire and Merseyside, which will look at then efficiencies and standardisation of practice. And as Claire says, coupled with that, we'll have a standardisation of sort of financial and sort of BI monitoring for it. In terms of the current other piece of work, we've engaged a third party who've sort of come highly recommended to work with 3 places initially on just that, looking at the backlog, looking at the practice, so we've already handed over through all the sort of the IG process, information governance processes. We've given them some of our waiting list, our backlog waiting list around fast track and one-to-one care packages. So we're testing it out with 3 places. If it proves successful, it's both a financial success in terms of getting the service more efficient, but making sure the outcomes for the patients are better and their families. So we're doing that, and hopefully we'll see some progress before the end of the financial year. And if we have, we'll probably look to keep them engaged for at least another year or so after that. But I think it'll be a continuous review. If that company and that organisation works well with us, we'll continue with them. But it's also about embedding their sort of good practice within the service, and that sort of couples up the work that Chris is leading on as well.
Okay, good. Thanks for that more detail, and clearly that could be, that must be, I guess, formulated into a programme plan where the Finance Committee can see and measure progress in impact and understand those risks. I'll take any questions on planning for next year. That was a part of this paper. Is there any questions or comments on that before I'm going to bring Graham in at the end? Okay, is that you with your microphone? Erica, have you got your microphone on there? Do you want to speak? Oh, no? Okay, Graham, do you want to?
Chair, if I can just say, I've worked in the NHS for 35 years now, and this is the most difficult financial and operating environment that I can remember working within. And I just want to take this opportunity to thank and commend Claire for what she's doing on all of our behalf. Her ability to negotiate with NHS England to secure additional financial support for Cheshire and Merseyside itself is really, really important to us. But also, we are the ICB with the largest number of organisations in the country. So just recognising the effort and the amount of work that is involved in negotiating with all 17 of the organisations to be able to land a plan, negotiating mutual support within those organisations and making sure that we collectively live within our resources is not to be underestimated in any way, shape or form. So I just want to say thank you, Claire.
I'm sure we all echo those thanks. Thank you, Claire, and to the team.
Sorry, can I, sorry, at the risk of this being a bit of a, I do want, given that Graham's just said that, I really want to reflect on the way that the finance director community in Cheshire and Merseyside works. It isn't like that everywhere, and it is, you know, it makes my job and the work of all of this board and the whole of the system so much easier and more successful. The challenges don't go away; they don't get any easier as a result of that. But it really is remarkable, and I think I'd just like to say that so it's not me; it's the whole system and the provider finance directors and the associate finance directors. Incredible system working.
Yeah, that's a really, really important feature, isn't it? The relationship we've got across the systems. Good. Yeah. Thank you. If we could move on to quality and performance report.
Thank you, Chairman. This is the second time the board's received the report in this format, so hopefully people are getting used to the style. And obviously later on we'll open up to questions from any aspect of that from either myself or my colleagues. But there's 3 probably categories I'd like to draw people's eyes to. And the first one, which would be remiss not to at this time of the year, is to talk about our urgent care system. We know that, as has been referenced earlier on, that this is the busiest and most challenging period of the time, a time of year for us. And we knew going into this particular Christmas and New Year period, it was going to be exacerbated by obviously the impact of industrial action, but also some forecast really cold spells, some real expectations around seasonal flu and others, which affects not only patients but our staff as well. So when we looked, when we last met in November, we were talking about winter is already here. And I think when you look at the dashboard, you can see how, certainly in terms of ambulance response times, how that was manifesting itself during November. So recognising that sharp downturn, the system came together collectively, not only to start looking at the robustness of the plan it already had, but what other measures it would need to take with that challenge further to come. And one of the key things that was all agreed was that collectively the biggest risk in the system in terms of urgent care was that of the unknown patient, that patient that's awaiting a response from an emergency service, predominantly the ambulance service, and how long it was taking to respond. In December, it had shifted to the worst from the position we've already seen in November, so everyone collectively discussed that. And the MDs in particular came forward with an approach that would could be seen as shifting the risk into another part of the system. But absolutely, everyone was united in trying to achieve ambulance turnarounds as the primary objective. And as an ICB, we endorsed that approach by saying that at the moment, you know, we particularly look at acute performance in the ED, and we look at not only how fast they turn ambulances around, but how long patients stay within that department. And we were endorsing, were it necessary, to say that, you know, we agree the primary risk is that of the ambulance, and therefore if that meant, unfortunately, the ramification was longer waiting times within A&E, that was still the less risky option. Having said that, everything was put in over and above what we'd already planned. NWAS, our ambulance colleagues, increased vehicles on the road. They were running at times with over 30% of the normal complement of double-crewed ambulances on the road to help out from that perspective. Our acute sector providers did and have now have general and acute bed capacity open to the tune of over 100 beds more than was planned, and that in itself was a plan higher than the same period last year. Our mental health providers were taking the same approach to escalation and management of real-time issues as was reflective of physical health, and primary care provision across the whole of the patch was also increased. We also obviously had to take down an awful lot of elective activity, planned activity as a result of industrial action, but there is also a level of elective activity that's traditionally took down at this part of the year as we go into the new year where it's most challenging. We will in time produce a full winter debrief, which we'll report back to on the board, but what I would say is the initial observation that I had is that the efforts that were taken during that December time frame paid off in the sense that on that Friday before Christmas, the acute bed occupancy was varied in the sense that specialist trusts were probably hovering in the late 70% occupants, and the acutes were still in the high 90s. But that was a significant improvement on the same period last year, and everyone will recall from last year's winter debrief just how challenging it was through Christmas and into the new year when the hospitals were already full. So we'll come back to that at a later point. What I would say is that as we came back in the new year, we did face that challenge, as it was a nationwide challenge, as the plans for industrial action and the shifting of senior decision makers throughout the system, and that balancing of risk that had been discussed heavily during December paid off, and ambulance response times were very, very high performing during certainly the first 2 weeks of January. We're very different than it was last year. But what we need to recognise is how that manifested itself elsewhere. So I think, you know, Anne will lay testament to her own organisation, but we saw accident and emergency departments running with in excess of 200 patients in them at any point in time, and over 100 in overnight, not what anyone would expect for our populace. But if I was trying to come back to the primary focus, the ambulances were responding too fast, and those patients were getting to an increased place of safety from where they were. So as I say, we'll come back to that at a later point. The pressures continue right now. It's not out with what we would normally experience at this time of year in a January. But again, the system, I would honestly say the system is not there pointing fingers at any other part of the system as a challenge. It has worked collectively, solidly throughout the whole of this period, and has accepted a real shift in risk to achieve that. But it's still ongoing. Just turning to elective, if I may, Chairman, we did talk earlier on about the industrial action impact. I think we believe that the figure, after taking into account what Graham said earlier about the way in which we plan for periods of industrial action, we think there's about 130,000 planned activities that have been impacted so far during this year. And an awful lot of credit to the system in how it recovers from that and gets that activity re-provided. So that the system is still running at about 4% higher in terms of elective activity than it was this time last year. And that is panning out in how we are addressing our staged approach to the reduction of long waits, and also challenges to try and stabilise the overall growth of the waiting list. So at this point in time, we are still working flat out to achieve the objective of 65-week maximum wait by the end of March. There are some challenges around that. The system is working well to collaborate and offer mutual aid from provider to provider. And we certainly expect the elimination of the 78-week waiters that we currently have. The 65 weeks at this point in time, we should be in a week or two's position away from knowing exactly where we expect to land, notwithstanding any other further impact of industrial action. Within that, Chairman, you referenced earlier the diagnostics, and I'll couple that into two elements really of my next bit. The indicator that we see on page 113, which is the patients waiting more than 6 weeks, that's for all referrals, both urgent and routine. And what we'd say is that at this point in time, just like the elective long waiting target, there is a staged approach to getting on top of some of these waiting times which was manifested themselves during the pandemic. So the objective for this year is to have no more than 10% of our patients waiting longer than 6 weeks, clinically categorised within that. At the moment, we are running around about 15 in real time, but that's moved from 22 earlier in the year, and that is down to that extra capacity that the community diagnostic centres have brought online, which is benefiting the trusts and the community referrals. And most of that reduction that we've seen from the 22-23% at the start of the year has been achieved in the past 3 months. And because that capacity is there, we do have a confidence that it's starting to pay off over the next few months. And we do believe that at this point in time, we will achieve the objective of no more than 10% by the end of the year. Where that's also playing out, and I'll close that and open up to questions if it's okay, Chairman, is a good news story around our cancer performance. In terms of, again, the backlog that was created post-pandemic, but also the surge in referrals meant that nationwide, the objective of achieving 85% of patients treated within 2 months from referral has been challenged throughout the whole of the country because the backlog is much, much greater. What I'm really pleased to report is that in Cheshire and Mersey, we have now returned the backlog to lower than pre-pandemic levels, and that's been achieved 4 months ahead of our schedule. It's why you see in some of the indicators already a very quick shift in terms of our performance. We're now 6 out of 42, performing the highest, 6 out of 42 in terms of our 62-day performance. I expect that to increase throughout the next few months now that backlog's got down to a level that should allow delivery of 85%. Within that, we still do have some challenges around the new faster diagnosis standard, so that is a referral to consultation, diagnostic, and either confirmation or ruling out of cancer within 28 days. There are one or two of our trusts that have already achieved that. And again, we're now expecting, now that we've got that diagnostic capacity, now that backlog's coming down, again, that's something that we do believe is attainable by the end of the year. So I'll pause there if it's okay, Chairman, and open it up to questions of both myself and colleagues.
Thank you, Anthony. Any questions or comments? Paul? Anne?
Thanks, Chair. It's on a specific item about dementia diagnosis rates. First of all, thanks to Anthony for including this for the first time. I'm quite pleased to see that in the last month recorded, we've met the national target across the whole system. My point is, though, that the target, I feel, is incredibly low. To have a target of 2/3 of diagnosis of people living with dementia, I think is not really good enough. And I know that Liverpool and Sefton have both set local target rates of 80% for diagnosis of dementia. I wonder what potential there is for within the ICB across the whole system for us to increase our target and to encourage greater diagnosis of dementia. Basically, we've got 1/3 of people living with dementia with no formal diagnosis. I don't find that good enough. I'm really pleased that, as I said, that it's here now and we can focus on it.
Thanks. Does anybody want to make a comment on that, team? Owen?
Thanks. We must always challenge ourselves to do better in the care that we provide for patients. And I think there are some national changes that are probably going to drive exactly what you are asking for, and rightly so. So there are some new pharmacological agents that are in development for dementia, whose effectiveness is predicated upon the earliest diagnosis that is possible. So I think that will drive us. A lot of the time we are challenged in trying to do better if in the response to finding something is not meaningful. I think that is changing now, as I say, with new agents in development. It can only be right for families as well to try harder at this, but it's challenging, and it relies on the way we communicate with our communities about coming forward to seek advice and help. So I would absolutely endorse that we need to be more ambitious, and I think there are things coming that will drive that further as well. Thank you.
Thanks, Rowan. Anne?
Yeah, I think it's right that we should acknowledge all the amazing work that's been done to keep the wheels on the wagon over a very, very difficult winter. And, you know, the staff have been just incredible in the way they've met the challenges that have been presented to them, which have been, you know, far. I've been in the NHS longer than Graham, and you know, this is by far and away a situation we've never been in before in terms of the pressures that we are being subjected to. And I just think it's right that we should acknowledge that that's where we are. It's felt a little bit like we're, you know, fessing up to some of the downside of all of this, and you know, where we are now. So I was just looking at the occupancy figures for my 2 acute sites just then. One's 109% and the other's 115% yesterday. So that means every single bed in the hospital's full, and there's another 9% or 15% of patients who are actually parked in A&E. And obviously that's an appallingly bad patient experience and an appallingly bad staff experience. So, you know, when we listened to all that stuff about the workforce, I was thinking, you know, the best thing we could do for them is to take some of that pressure away. That would be the best thing of all of those other things we do, if we could only take some of that pressure away, and the financial consequence as well. I mean, that mathematics of how much money we're spending on, you know, all of those extra patients that actually, you know, aren't in our traditional beds. And, you know, we're doing all that because we need to keep the ambulances on the roads. Absolutely committed. And the system is working together as well as the system could work together. We can't even, like, you know, as Claire was saying, we are really working very well together as a combined system and supporting each other, and we're pulling everything else that we can to try and keep elective activity as high as it can be, keep the diagnostics right, keep the cancer pathways in place, despite all of the non-elective pressure that's going on. But I don't think we can kind of not acknowledge the fact that where we are right now isn't where we need to be in terms of the patient's experience we can deliver when we've got just that much over demand going on compared to the capacity that we've got to meet that demand, because really it isn't a place we'd want to be ever, in terms of we've just got too many patients who are not receiving the standard of care I'd like to be able to provide them with, because we can't get them into the beds in a timely way because we don't have the beds to put them into. And I think we just need to acknowledge that there's a kind of cloud hanging over us in terms of that there's a real pressure going on out there that we need to acknowledge.
Thanks, Anne. I'm sure, like I said at the beginning of the meeting, and I'm sure everybody around this table does acknowledge that immense pressure, both on our staff and also the consequences it has for our patients. Before I bring Warren in, and perhaps when Laura and Mark do your place-based reports, perhaps you might want to comment on the system working and the initiatives that we've got. And from your perspective, are there any other areas of focus that we need to get more time and effort on?
Yeah, I mean, part of the problem we've got is the issue with patients who need to be in social care, and I do think there's still lots of room for more innovative ideas around what we could do, because what we're doing now is providing incredibly expensive acute beds for people who might need a much less expensive package elsewhere. So I do think from a system work point of view, crossing sectors, I don't think we've optimised where we might be from that point of view. And that would, tackle the biggest problem we've got right now, which is the problem of there just not being enough spaces to house these patients. So I think that there's room for greater thought and innovation about how that might be tackled.
Thank you. Yep. When we hear from Mark and Laura, let's hear a bit on that. Helen, are you trying to attract my attention?
Yeah, I will. I've not seen these statistics before, so it's a genuine question of, and it may be that other statistics are placed elsewhere. But I would be interested to understand a little bit about these stats in relation to discharge and wellness. The word quality is very much present in this paper, but to understand a little bit about how people become well as a result of these statistics, but it might be that I'm just not understanding them.
No, I think you're right in terms of looking at this data, and does that answer your question about are we improving overall population health and wellness? You can't readily see it in the data. Graham, have you got a view about how do we start looking at that?
Can I think about that, Chair? Okay. And come back to you.
Okay. Ruth?
I'm not going to pick up the point about wellness in the meeting, but I'm happy to have a conversation about how we can switch our focus to support people for better outcomes. I just wanted to pick up, and I don't apologise for bringing it up again, I raised it at the last meeting, is the healthcare-acquired infection rate. The data don't show any sign of improving. If anything, they're slightly worse. My question, and I realise the pressure the system is under, and that adds a challenge for people to reduce healthcare-acquired infection, but this is harm that is created in those settings. So it talks about at the end of Q3 there'll be a review of the improvement plans, and I suppose what I'm looking for is some assurance that those improvement plans have been looked at, because we're now into Q4, and that we are confident that these data will improve, that we will reduce the harm from healthcare-acquired infection. My second question was around never events. Again, the report suggests that we have made no dent in the rate. It says it's the same as last year or the previous 12 months. And I see there's been an event to try and raise the profile of this. These are never events, but we had 29 in the last 12 months. So just want assurance on both those points, please.
Okay. Infection control, is that Chris? Are you going to give us a...
Yeah, thanks, Ruth. So from an infection prevention control point of view, I mean, we liaise through our contract management meetings, quality contract management meetings with each of the organisations around their healthcare associated infections and the data, and that feeds in through the Quality and Performance Committee. I mean, we met with one of the organisations on Monday this week to look at their position within their quality and performance. And we raised healthcare associated infections, particularly the C. difficile toxin rates. And so each of the providers has got an improvement plan. We are working with them to achieve those, and we feed that back. But I do hear what you say. It features in our quality and performance key areas of risks, and we feed that back through to region as well. And we're working with region too. And I think if you'll be aware of the Northwest as well, that it isn't just specific to Cheshire and Merseyside, but I appreciate that we need to get those improvements in place.
Chris, just on that specific question about have we reviewed the recovery plans? I don't think you answered that.
Is it the improvement plans? Well, we would review those through of the quality contract meetings that each of the places hold with their NHS provider for which the contract's held. So that would, I mean, I don't know if the place directors can say that that would be picked up through there.
Could
Our quality leads will pick that up.
Okay, well, could I ask you just to look at that and
sure.
just make a comment outside the board meeting whether we've done that or not? Thank you. I think I've got Claire, Rowan, maybe somebody over Ian.
Well, yeah. Oh, sorry. Did you go first, Rowan?
Claire? Oh. Rowan, you
so
on this topic?
I was going to respond to the question about never events. I suspect colleagues will speak to the population health.
Sorry, yes, I've missed that. Go on.
Point. No, that's quite all right. So never events are so called because these are things that should never have the opportunity to happen, and yet they do. And you're quite right to pick up that this has not shifted, and that is not good enough. So I've met with all of the medical directors to get a sense of, what would allow you to better get behind this and approach it, because often it means that any individual trust has had perhaps one, and sometimes two of these things happen. I've personally been through the situation with an organisation where we'd struggled and looked to better understand it and get behind it, and so often it's human factors. Most of these are happening within surgical settings of either wrong site procedures, most commonly, and occasionally returned medical devices or some such, all of which, given we have checks at the start of every procedure to confirm, and that we count everything in and out, does feel an incredible situation. So having reviewed that with the medical directors, they felt they were struggling with, say, single situations, and we've said, right, there is clearly a move to thematic learning across the NHS through PSERV. We will take precisely that approach. So we are bringing together our medical directors, our surgical clinical directors, and the operational senior leaders within all of these organisations to fully understand the themes and what approaches they should take back to their organisations to tackle some of this, and then look to see precisely what impact we have on that. That is in its detailed planning stages and is planned for March time to make sure we have everybody in the room. You're right, it's an awful place to be and high on our consideration.
Thanks, Rowan. I think I've got Claire and then Ian.
Yes, if that's okay, Chair. I'll start off and hand over to Ian for probably more detail, just in terms of the population health question, Ruth. So we have made a commitment to bring more population health information to the board, and we'll do that working together with Anthony and his team. But obviously we have a number of different committees and fora where that's discussed, in terms of the Population Health Board, Reporting to Transformation Committee, and obviously the Healthcare Partnership. We've just made a commitment that we will adopt Altogether Fairer, refresh Altogether Fairer as our HCP strategy for 24-29. I've got my years right, I think that's 5 years. And part of that will be how we as an ICB respond to that in terms of our joint forward plan. And all of that planning side of things will come through to March's board meeting. But I think in terms of the indicators, the MARMA indicators are sort of the golden thread and Altogether Fairer. So it's how we bring that into this board meeting a bit more, I think, Ruth, in terms of that sort of wellness and population health. But I don't know whether, Ian, you want to add anything else?
If I could, really, and taking on your question, Ellen, on that, there is a new duty as well that's landed through the NHS on health inequalities, and a duty to produce a statement on that. We sort of tried to preempt some of that with how we were trying to bring metrics through to the board and what we were looking at in that angle, and that what was getting measured on a regular way, because some of the beacon indicators we got were only getting done on an annual basis. So there's a definite piece of work there with the new duty aligned with the altogether fair recommendations that it might be that we need to produce a separate report, and I can link in with, obviously, with the Chief Executive on that in coming back to you.
Thanks, Ian. Have you got further to add?
Yes, if I may. Sorry, I just wanted to reflect and think before I answered that question. And to thank you, colleagues. So I think the first thing is the MAMA Altogether Fairer work will give us a long-term view of whether we are improving the health of our population over a period of time. And it's our intention to report back our progress against the Marmot initiatives through the Healthcare Partnership. But we should bring a copy and a summary here to this board. But one of the issues that I try and wrestle with is trying to make a distinction that says the work of the Healthcare Partnership will principally concern itself with those issues of primary prevention. But actually, if we think that then this board is more about how we run the NHS and all parts of the NHS, then this board should rightly concern itself with the question of secondary prevention. Now, if we brought to you every single thing that we can and do measure, then this report would be so long that we would kind of completely lose sight and we'd lose the wood for the trees. But we do have a range of things that we are measuring in the secondary prevention agenda. We're measuring them routinely, and we can report and indicate within these reports progress that is being made. So, you know, the obvious example, and it goes, I think, quite nicely to Paul's question about dementia detection, because once you've done the dementia detection, the question then is, what do we do about it? So one of the other big pieces here for us is at any given point in time, we are measuring by GP practice the number of people who have both their diabetes identified, but also whether they have their diabetes under control. So within the NHS, we have a set of measures that say, are we helping the population towards that degree of wellness? Now, I wouldn't propose bringing this into every one of our meetings, but I think the question is, in perhaps the summary from the primary care committee that comes back to the board, we could indicate a deep dive into something called the Quality and Outcome Framework Performance, which would give us an indication of, are we doing the secondary prevention things to improve the wellness of our population? But I would be really pleased, and like Ian says, we'll triangulate a conversation outside of here so that we can demonstrate to you how we're starting to join these things up.
Okay, thank you. Thanks, Graham. Perhaps if I could summarise that answer to Alan's question, and correct me if I'm wrong, it's really, really important that we position this in the right place. So I think what's been suggested is that at least on an annual basis, we will see, based on the 22 Marmot indicators, we'll see some information and report on that. In addition, Graham, you're suggesting that we will see some secondary prevention measures coming to this board so that we can see progress on that. And at some point in time, we do need to do that triangulation that says, here's all these other indicators and how do they contribute to the overall population health. Yeah. But is that essentially, Ruth?
Sorry to come back on it, but many health systems are using patient-reported outcomes to assess whether or not the healthcare that's delivered is actually making a difference that matters to patients. It's not just the clinical result, but did it add value in the person's life? And it's particularly helpful with lots of chronic illnesses. So my question is, do we have a systematic way of looking at patient-reported outcomes? And some of the health systems around the world are using it to actually inform the clinical decision with the patient as to the likely benefit of having a treatment, a procedure, wherever it might be. Are we systematically investing in patient-reported outcomes and using it in that way? And do we, if we're not, do we intend to?
Sorry, we use PROMs selectively. We'd have to go away and have a look at the data that we are collecting and where we're reporting that.
Okay, so that's an added characteristic of the data that we would want to see here at the board at the appropriate period. Okay, thank you. I'm going to move us on, given that we're about an hour behind. Tony, we're on to your report. Again, just give us highlights and we'll take questions and comments.
Yeah, thank you. Just to say, in the alert section, we continue to look into staff shortages that are affecting maternity services, particularly band 5, 6, and the impact it has on induction of labour. So we continue to focus on midwifery issues, staff shortages that impact on induction of labour. But if you look down to the Assure section, there is a recognition there that despite those staffing shortages, the delays in induction of labour have decreased recently. So there's a positive impact being had there, but we'll continue to look at that. We've already covered all-age continuing care. In this instance, what we're going to continue looking at the Quality Committee is the variance across places and try to understand as best we can what's driving those. I support Paul's comments there on the dementia diagnosis rates, which we've looked at just for the first time now. I think there's more work to be done on those. And just draw your attention to the positive work, we get challenging work around antimicrobial prescribing that's going on. So the Quality Committee will hear more about that in future meetings. Thank you, Raj.
Thanks, Tony. Any questions or comments? No, thank you. Right, the Place Director report. So you've produced two reports, Laura and Mark, and take those as read. Just highlight for us some key aspects, and especially in relation to the strategic imperatives that we've been talking about urgent care today. Laura, do you want to go first? Because I can see you, I can't see Mark.
Yeah, can do. So yes, I guess we are looking together as a partnership in place around what has worked well in terms of our integration of health and care in 23-24 and looking ahead to how that influences our priorities for 24-25. And I think it speaks to what Anne mentioned before in terms of that shift away from just the back door of getting people out to a more integrated community capacity that will reach in and be able to pull people back home, but more equally importantly, support people to avoid more of those unplanned admissions. So we are working on an innovative model in terms of community response hubs across our 9 local neighbourhood areas. And they are additional staff working and wrapped around community care teams, multidisciplinary, working with the primary care practices, but also with the community and community leaders through our community partnerships to have that really integrated approach to support people across health, care and the voluntary sector. So I think we are responding to that challenge from our acute trusts of them being the backstop at the moment to how do we create more of that capacity, skill, expertise in the community. But doing that within the financial constraints that we've got is really challenging, and we need to make the most of the opportunity we've got through the discharge funding and that commitment to work together. We've also implemented an innovative joint brokerage team that broker all packages of care as people are being discharged from hospital, so that we get the economies of working across health and care rather than competing with each other, and better relationships with the private market in terms of care at home and care homes. And we work to a set of shared KPIs, key performance indicators, to make sure that that turnaround is improved when we're trying to broker that care and reduce any delays. And equally importantly, we are focusing going forward on those community partnership relationships at our 9 community, local community level, to, instead of asking them to focus sort of from a top-down perspective on certain health improvement areas, we really want to empower those community partnerships to focus on wider determinants of health, and to talk to what Ruth was saying in terms of that wider prevention, patient person outcome measures, I guess. So thinking wider than just what we collect from a health perspective, but what outcome are people having from social prescribing, for example, which is a much harder challenge to capture. And then from a mental health and LD perspective, we are really focusing upstream next year and going forward on particularly children and young people and earlier help to address multiple challenges. So not thinking about how do we stop more people being referred into CAMS, but how do we support children and young people's emotional health and well-being much earlier, resilient in multiple ways. It can't be just about schools doing everything. It's about how do we wrap support around individuals and their families in their local communities. Schools being part of it, but not forgetting not all children are in school. So thinking about how do we reach those children who aren't regularly in school or are educated at home, and also importantly our children in care, so that we can really prioritise and focus on those who are most vulnerable and most likely to experience mental health challenges much earlier. I think that's probably enough from me. Thank you.
Thanks, Laura. Before questions and comments, Mark, do you?
Yes, thank you, Chair. I'll just add to what Laura said. I think in addition to that, one of the things I've just reflected on, so Owen talked earlier about the fact that integration, there should be more of it. So in St Helens, we have got an integrated team across the council and the NHS, and there's huge benefits to all of that. But some of the challenges that we've got, and Anne's challenge there, and convened a meeting with MWL before Christmas to say, right, what's the art of the possible here to bring all the sort of, I think the 5 places that you deal with, Anne, together to say, what can we do? And there was a whole host of things that we were looking to do. But minded of the announcement yesterday around the 500 million that's been promised to social care for children and adults, if you listen to both the County Council Network or the Local Government Association, there's probably well over a £4 billion gap. So although it's welcomed, that investment is nowhere near enough to be able to support the sector. So Councillor Cummings will be in the same situation as most local authorities, as we are in St Helens, is that we are overspending both in terms of our children's and adult services. It's because we're doing the right thing, because we need to make sure that we're protecting our children and protecting our most vulnerable adults and older people. However, the finances available to us to be able to do that are significant. And as I say, the money that was announced yesterday is welcomed, but it's non-recurrent, and we'll be back into that challenge again of how do we do that. The other things that are happening is there's Anne described the, more innovation in there. So as across the health and care family, we're looking at how do you have different options in relation to the workforce challenges that we've heard about today. So there's lots of things around assistive technology that can support. I'm also minded of, I was listening to Ruth many years ago around the whole piece around health inequalities and all the stuff that councils do that contribute to that. So what is it we're doing? You mentioned around children and education. A lot of the work that we focus around is trying to respond earlier and support not just our looked after children who are the most vulnerable, but there's a number of children that we work with every day, both in terms of our education settings. If we know they're out of school, then there's something not right, so we need to support them. And one of the pieces of work that we did through our Inequalities Commission, which our Director of Public Health led, with also our Chief Exec of the YMCA, was some of our young people were saying the kind of top things. Mental health, no surprise there, because we know that's a challenge. The other was about lack of opportunities, and the third was around money. So there are a whole host of things that we can do as a system, not just in terms of the NHS, because it isn't just the NHS's challenge to solve, but I think the challenge working in terms of local government and our wider partners is that there are a whole load of things that we are trying to kind of deal with at the moment, both at the backdrop of challenges around workforce, the finances, and then prioritising those things. The final thing I would say, Chair, and happy to take any questions, is that there is a lot of work that is going on in terms of investing in the right interventions and the evidence for that. And I would say that everybody, I know, talk from a St Helens point of view, everybody's working incredibly hard to achieve it. However, there are certain things that we will need to collaborate both in terms of an ICB footprint, and we're trying to do that on a Mid-Mersey, but there will be national interventions that will need to help to support some of this. Thank you.
Thanks, Mark. Can I take any questions or comments? Warren?
Thank you to both the place directors for that. It's really important partners for the voluntary community sector, and really appreciate what you're doing and how you're working with the sector. I'll just pick up in particular the piece of work that Laura's highlighted around hospital discharge. So it's just to thank Laura for looking at ways in which to maximise all partners' role in hospital discharge and address some of the challenges that Anne referred to earlier. So thank you very much.
Thanks, Warren. Further comments? A couple of comments from me. Bruce, were you waving me? Yes. No, go ahead. There you go first.
Well, first of all, say thank you. It's really interesting to see what's happening at Place. There is I think, comment in the paper that we note this, but also ask what further information we want from Place directors. And I guess what I'm trying to work out is how we connect the joint forward plan with our annual business plan, with Place being the mechanism the ICB uses to deliver the change that it sets out to deliver, and then connect that to the quality and performance report. So that's the thread I'm looking for when we see Place reports, is how does all that connect up? And especially useful to link the Marmot indicators on health inequalities. This is a rich place where we can get some assurance that the preventative work is happening as well. So it's both the connection through on what the NHS has to deliver, but also assurance that the preventative work is actually happening in Place, and the NHS is playing its full part in that. So that's the sort of thing I'm looking for from a Place report, if that's helpful.
I think it's very helpful. Mark, Laura, any initial reactions to that?
Yeah, Chair, through you. So thanks, Ruth. I think this is the beginning of how do we bring all of that together. So in our individual 9 places, so this is a report that Laura and I take to our individual place partnership boards, and in addition to that, similar to this board, there's a whole host of other information that goes there that is focused on us as a system working across the leadership of that place, and not just the NHS. So I think what we'll need to do in the future, because I know that we all do this in our places, so we're really clear in terms of our links around the Health and Care Partnership Plan, our, the planning guidance that's coming through now in terms of what we're going to do, in addition to what is our health and wellbeing strategies, and then the links to that kind of wider system delivery, both in terms of Marmot and Core 20+5 and all of that. So the trick will be trying to bring all of that together in terms of the 9 places, that you get something meaningful that you can see, interrogate, and then check and challenge. So I think that will be the challenge for us to be able to do that. But I know that we're all doing it in slightly different ways, but all focused on the same sort of thread that takes us back to the overarching plan.
Thanks, Mark. Paul?
Thanks, Chair. Mark's just touched on this a little bit. We've just had 2 place reports from 2 of the 3 authorities that have the more integrated approach. I just wonder at what stage will be a review of approaches and, as Mark said, the differences, and to see how effective and provide the links that Ruth just described. Are we able to do that more effectively through a more integrated approach? I would hope, as we're doing in Sefton, that's what we're attempting to do. But at what stage we'll review that and say to the other 6 authorities, maybe you should go down that route as well. And this is the best way forward to bring about the best for your population.
Good question. Graham?
One of the things that success is, I think, built upon is about people and relationships. But there's also a determination of context and the maturity of systems to move in that fashion. Now, at the moment, I would say, as we're a very new organisation, we'll take the opportunity to look at these things as and when change arises. So, for instance, our place director in Liverpool recently left us. we entered into dialogue with the City Council and we decided it was most appropriate to remain with the model that we had at this point in time. You know there's an awful lot going on in Liverpool and it wouldn't have been right to have kind of moved to another model. Now, at some point in time we'll perhaps bring a reflection back on the overall maturity and progress of each of the places, because certainly we engage in a quarterly review process that would enable us to do that. Whether now is the time of the right to say, let's do a formal review and move to another model, I think that's too soon. I think we've got to let it develop a little bit further, but we will in the meantime be opportunistic. So maybe I'd like to see us perhaps think about that come on the autumn time this year. You know, when the ICB has gone past more than 2 years old, but also when we have some indication of the political context we're working in, because a change of government, publication of new government manifestos will give us an indication of some of the big asks that will be placed upon us as we look forward.
Thanks. Gareth?
Sorry. In my current role and my previous role, I was heavily involved in the development of integrated community partnerships, neighbourhoods, community partnerships, as Cheshire West call them. And I fully agree with you. I think the work that's going on is really good, is starting to show some real benefits. I guess my question is around cross-border issues and whether or not different places are working together effectively. So in the community I live in, there is an issue whereby in terms of hospital discharge, there are blockages because the hospital trust is in Wirral and the community is in Cheshire West. And I don't know if that work is being done. It may well be, because my knowledge is about 6 months out of date.
Laura, do you want to give a view?
Yeah, absolutely. We have slightly complicated border issues with bordering on another country as well in Cheshire West. So absolutely, yes. I think that's the advantage of being part of a bigger organisation as an ICB. So working closely with our place director colleagues across those individual boundary areas that traditionally were separate organisations, and now we don't have that. So you know, we absolutely do see some benefits, and we've seen a real improvement in that flow back from hospitals out of area. I think the challenge with Wales is a lot more complicated, and there are some more escalations that need to happen with our Welsh colleagues because we don't have that same relationship. So.
Thanks, Laura. Anne?
Yes, our philosophy of working together as providers has been about sharing best practice, adopting anything that's turned out to be a really good thing and works, taking out variation, improving standardisation. So we're really like steeped in all this, and we talk about it endlessly and do lots of work on how can we actually do that. And, you know, and we've got real outcomes to show for it. And when you're serving 5 different places, like my organisation is, you really see that variation in the 5 different places. And, you know, if we extended that to the 9 different places, it would probably be even more stark. It just feels like there are some things we kind of know are more effective in some places than others. And I know we've got different contexts and background histories and all that stuff, but is that really a thing that we could say that about the providers? We've got all sorts of different stories going on. Is that really a reason not to say, if something is effective and working well somewhere, why can't we really try to take that more helicopter view? I think I'm supporting what Paul said, really, and say, do you know what, why aren't we just doing that everywhere, because that works better than it does, you know, than whatever else everyone's decided seems to be a good thing. It seems like we've got unwarranted variation, to me, in some of the practices that we've got, and that we could do better than we do by just taking out some of that variation that's there.
Thanks, Anna. I'm just going to sum up very quickly.
We will shortly be going through the process as Ruth asks, you know, from our 5-year plan to our annual plan to the objectives that we set to all of the leaders in our organisation, we will shortly be going through a process with all of our place directors to look at how we're going to develop and set their objectives for the coming year. And within that, we're already thinking about a wider consultation with partners whom they are working with to actually influence those collective objectives. So I think there'll be a good opportunity for us to put into those how we go for further standardisation, how we tackle variation. Chair, if we're concluded on conversation on the place directors items,
no, I'm just
I wanted to make one more comment on the place director report, if I may, but I'll
no.
wait.
So, and ask, really. I'm trying to synthesise Ruth, Paul and Anne's comment and requests of us. I think how I could synthesise this into an ask of you being team and absolutely hear and accept and fully understand that we're a maturing organisation, but we are going to be 2 years old soon. I think by the autumn, and I think that's the timescale you suggested, we do need to see here at the board, I'm going to use some language that I'm used to, but perhaps hopefully it's understandable. We do need to see a target operating model for the ICB. We need to see that for each place, and we need to understand what the maturity of each place is against that target operating model. We need to see the learning system that happens across each of the 9 places, how do you share, bring things together. And we need to focus in on some of our priorities to understand where do we drive out, where are we going to put our time and attention first to drive out unwarranted variation. That's a really, really important part of the maturity, I think, of the ICB and the ICS. So that's an ask of you. We're saying we'll have a meeting in November, I think. It feels really, really important.
I understand the question, I understand the timeline. I would want to agree specifically the scope of that with you so that we know that we are meeting the board's expectations.
Good, thank you. And you wanted to say something finally?
I just wanted to link something that's happening in Cheshire West and Chester back to something that Erica said earlier. And that's associated with the provider selection regime, just so there are no surprises. In the mid-2000s, there was a government initiative to expand the number of GP practices in this country, and those contracts were let in a certain way. And these are sometimes called PMS or APMS contracts, as opposed to what most of our GPs work under, and that's GMS. We are out to tender for, I think, 3 such of those contracts in Cheshire West and Cheshire. 4, Laura is telling me. Yeah. And one of the things that's really important about that is the cycle and the legal requirement to launch that tender process had commenced before the provider selection regime came into law, and therefore we are continuing with the old regime for how we tender those services.
Pity. Thank you. Happy to move on. Highlight report of the Chair of Audit. You can see that Neil's put a comprehensive report. Are there any questions or comments? No? Good. Tony, Remuneration Committee? There's an approval scheme.
As written, Chair, I just asked that the board approves the terms of reference changes that are set out in the report.
People happy to support that approval for the terms of reference? Yes. Okay, thank you. Erica, Primary Care report.
Just back to the audit one, Neil did want to say, he did have a quick word with me, that the 4 risks that were assigned to auditing risk came in at escalation at 20. 3 have now moved to 9 and 1 has moved to 6. And why have they moved? It's evidence that systems are now being embedded. So it's really good news. So that's audit. Thank
We'll
you.
add that to the minute.
In terms of primary care, there is just one alert. So there has been a change from NHS England, and 4 new providers have come into the EPR market. We thought that was quite unusual, given the strategy on digital tends to be convergence, not divergence. So we have marked that as a risk, and if John was here, it is on their operational risk. You've got the risk of practices changing and what that might happen. So we're just monitoring that at the moment. That's it. Thank you.
Thanks, Erica. Any questions or comments for Erica? No, thank you. Clerk, Transformation Committee.
Yeah, thank you. So one alert around pulmonary rehab. So we received a paper on pulmonary rehab and the programme funding. So that was managed within the approved standing financial instructions of the committee. But I thought it was an opportunity to raise awareness with the board of the ongoing risks we have as a system in delivering our long-term plan commitments due to the changes in NHS England and the reorganisation and funding for the clinical networks. And I know Fiona would like to just raise a couple of points on that, if that's okay, Chair.
Thank you, Chair. So clinical networks were set up and funded by NHS England nationally to address clinical priorities and targets within the long-term plan. Some of these are on a northwest footprint, for example, the renal network. But the ones that we are particularly concerned about were the ones that were on a more local ICS footprint, so specifically stroke, diabetes, respiratory and cardiac networks. At the establishment of the ICB, our ambition, both from my perspective and that of the clinical networks themselves, was that the networks would become embedded within, become part of the ICB infrastructure. As you know, ICBs have gone through a running cost review, and NHS England's regional teams have had a very similar management of change process, which over the last 12 months, which is just coming to an end. The outcome of that is that the clinical networks have had their staffing levels reduced between 30 to 50%. And they have had to reorganise, and they've reorganised themselves onto a northwest coast footprint, which means we are sharing the reduced resource across the two ICSs, so ourselves in South Cumbria and Lancs. So the impact that that has is that the national clinical programmes are still giving money to the clinical networks and have the same level of expectation, but the networks have significantly reduced capacity that is causing considerable stress for the staff involved, and a lot of uncertainty about how we go about working with them at ICS level. But we're getting there. We've kept really close to the whole process, and we've built up some really good relationships, but we've got some new people coming into post as a result of the reorganisation as well. So that just presents a slight risk for us.
So Fiona and I wanted to raise that with the board and just say we're managing it, and it sort of comes through the Transformation Committee, but I think it's just something we wanted the board to be aware of. So just another couple of points from the Transformation Committee. We approved funding for a standardised approach to programme management across the ICB, which will be working in place and in sort of corporate teams. And then we also agreed to review the terms of reference of the committee as we take on more responsibility for specialised commissioning. Obviously, with Ian's appointment, the Population Health Board already reports to the Transformation Committee, but we wanted to sort of strengthen that, and also some of the more integrated commissioning. So we'll hopefully come back in the March report with recommending revised terms of reference. Thank you.
Thank you, Claire. Any questions or comments for Claire? No, thank you. And if we can go on to the next agenda item, again, Claire.
Okay, so this is the Q3 update of our principal organisational risks. You can see we have 10 principal risks, 4 which are scored as extreme, 3 high and 1 moderate. The most significant risks are detailed very shortly in 2.2, but also in 9.2. We've worked through that there have been no changes in the risk scores since November, despite mitigations to those risks. But you can see in 9.3, the BAF risk where mitigations are having an impact, and we can see a reduction in the other risks. So you can see that. Considerable work has taken place during the last 3 months to strengthen and implement the controls which will reduce the likelihood and potential impact within our 5x5 risk matrix, and 9.4 details these. I'll stop there, Chair, but obviously welcome comments and feedback, and myself and colleagues who are the exec leads for the risks can answer any questions, but obviously also invite chairs of the committees, to comment, as obviously they've raised risks within their chairs' reports. Thank you.
Thank you, Claire. So for board, this is the way that we document our strategic risks of a significant value for the board to see and track. I must say, I'm really pleased with the way this is developing, and for example at Appendix 3, the way that we get the detail that lies behind the assurances and controls, that's really useful. Any questions or comments? It's here for noting. And it should be a live document as well, shouldn't it, Claire? People can feed into it as and when issues happen. Yep. Should we move on to the corporate risk register?
Okay, so this is the first time we've brought this to board. So the ICB's corporate risk register is made up of those risks escalated from committees and directorate risk registers that score 12 and over and have an impact on the ICB wide. It also includes those risks aggregated from our multiple places that have a score of 12 and over and have in relation to an ICB-wide impact. So we currently have 8 risks that meet the criteria for the corporate risk register. 5 are scored as extreme and 3 are high. The extreme risks are detailed in 2.2 and 9.1. Colleagues and myself can answer questions on those once I've finished updating the board on the rest of the paper. We also have a pipeline of risks which may meet the corporate risk register criteria once they've been reported and scrutinised to their respective and appropriate committees. You can see in the report that we're looking at 7 through the Women's Services Committee, 4 through the Digital Services Board, and 1 or 2 both through Quality and Performance and the Transformation Committee. I'd also like to remind Board of the Organisational Risk Committee, chaired by our Chief Executive, which reports to the Audit Committee. All members of the ICB's executive team are required to attend to ensure a consistent approach to risk management and the scoring of risks. At each meeting, which takes place every 6 weeks, place and corporate directors outline their respective top 3 risks and outline the mitigations and controls they have in place. The Risk Committee has also commissioned some external organisational training in risk management and will support the review and refresh of the ICB's risk strategy, which I'm hoping to bring to March's meeting. I'll leave it there, Chair, but obviously happy to take any questions and comments from anybody. Thank you.
Any questions or comments? Just one from me, which just ask the team to look at again. I was surprised to see the score of 6 around P2. I think it's the inadequate diagnostic and data infrastructure, partly because of what we just heard about more providers coming into the primary care market. But it felt really low given the scale of what we need to achieve. But if I could just ask you to look at that again, perhaps through the chair of the risk committee. Any other questions or comments on this? No, thank you. Here for noting. Chris and Thomasina, let's go to the anti-racist framework.
Thank you, Chair. I'm going to invite Thomasina Offal, who's our Associate Director for Equality, Diversity and Inclusion, just to provide an update on the work that she's been leading around the implementation of the North West BAME Assembly Anti-Racism Framework.
Welcome, Thomasina.
Sorry, is this it's on? Okay, thank you. This report is to give an update of the progress to implement the anti-racism framework, which is the North West BAME's Assembly Anti-Racism Framework. The report itself is self-explanatory, so I won't go through that. I'll just highlight some of the issues in there. So the report is split into 2 parts. What we as an ICB are doing as an organisation, and then what work is being progressed within the system. So as an organisation, our places and our functions were invited to do a self-assessment, just so that we could have an understanding of what was in place already to kind of implement the anti-racism framework. What came back, we had a 50% response rate, and what came back, the results of that was quite poor in terms of our understanding what anti-racism is, and also what kind of activities we have in place to meet the different criteria for the anti-racism framework. That in itself is not concerning, and it's not surprising given that we are a new organisation. So based on the results that have been returned, my recommendation to this board is that we actually go forward and put ourselves to achieve the bronze level of the anti-racism framework. We can achieve the deliverables in the framework at bronze level by the end of the next quarter. We will also achieve some of the deliverables at silver level. Within the system, the vast majority of our trusts have pledged to implement the framework at bronze level. I think there's 2 or 3 trusts who haven't indicated that they are going to do so. One trust is thinking about their commitment to the framework, and that might be because they've adopted a different framework. Trusts are able to get support from the Northwest region, the NHS region. We have drop-in centres, drop-in sessions, so ourselves, the ICB, as well as our provider trusts are able to kind of identify support from those drop-in sessions, and from the ICB itself, they receive support through our Patient Equality Focus Forum. That forum meets on a monthly basis, and 3 to 4 of those monthly sessions have been allocated towards supporting work around the adoption and implementation of this framework. There is much interest within the primary care networks to implement the framework. Now, as it stands, the framework is not fit for purpose for primary care. So we are working with the North West BAME Assembly and with the race lead for primary care within Liverpool to kind of adapt the framework so it's more fit for purpose. We've had support from the local medical associations, councils, who've said they're very, very supportive of this implementation. They've also agreed to work with us to establish an EDI GP council or steering group to progress this work. In addition to this, we have established a BAME staff network within the ICB. Now, membership of that staff network has been open to the primary care. And one of the reasons it's been open to the primary care are twofold. The first reason is that primary care has expressed an interest in implementing the framework, but there's been a lot of information that's come back through the network around GP's experience of racism and how their particular practices, individual practices, are ill-equipped to tackle the racism that the GPs are facing. The second reason is the low numbers of BAME colleagues within the ICB organisation, so there is a sense of a lack of safety. But as we develop and as we progress through the work, particularly the anti-racism framework work, I expect those numbers to increase. Already levels of interest from primary care have increased, not so much though from the organisation. So there's more to do about understanding reasons why staff may not want to engage with our particular staff networks, not just the BAME staff network, but all of our equality networks. So our next steps for this agenda is basically to progress the implementation of the deliverables under under the bronze level. So that will require developing our staff network's capacity to engage with the agenda, to identify some KPIs, race-based KPIs that will improve staff's sense of belonging, but also address some of the systemic kind of barriers to staff feeling welcomed and included, but also that prevent progress and recruitment of BAME staff from our communities. I'll leave it at that stage. Any questions?
Thanks, Thomasina. I open up to questions and comments. Claire?
Thanks, Thomasina. Thanks, Thomasina. Thank you for bringing this. So, in terms of the internal ICB work, so I was pleased to see my team scored in terms of quite high in the response, but the actual framework itself was quite difficult to complete. We discussed it as a directorate senior team, and I have to say it wasn't the easiest and most intuitive document. So whether in any future iterations we can maybe sort of bespoke that internally, because it was quite difficult, which is maybe why some of the responses weren't forthcoming, but I think it's really important, so thank you. The other point I wanted to raise was around anti-racism framework and primary care. So welcome that work and thank you for doing that, and obviously working with the local medical committees, but can we extend that to the other 3 contractor groups? Because obviously we have 2,000 contractors across Cheshire and Merseyside, and we're now responsible as an ICB for community pharmacy, dental and optometry. So I think it would be really helpful if we look at the whole range. I appreciate we might want to start with general practice, but I think in any delivery or implementation plan, we look at how we include the other 3 contractor groups. And obviously through Erica as Chair of System Primary Care Committee, I'm sure we'd welcome an updated report to the committee at some point in the future. So thank you very much.
Could I just give a response to your question about the framework, if that's okay? The questions that were asked were they were set that way on purpose because I needed to get an understanding of where the organisation is in its understanding of what anti-racism is and what work will be involved. Now, next month, there is a development workshop session with BRAP. BRAP is an experienced organisation leading NHS organisations through anti-racism. And so that development opportunity next month will actually flesh out what is required, so it will answer a lot of your questions, Claire.
Okay, lovely, thank you. Thanks.
Thank you. Ian and Chris.
Thanks, Thomasina. I'm over here. It's great seeing this coming through, and it's quite helpful. I'm just looking at the diagram with the summary of direct deliverables, you know, in the categories of bronze, silver and gold. And I was just wondering, how far off do you think we are to getting to silver and progress to be done? And the other one was just, I know a big piece of work is on about data quality and recording is really, really important, which is one of the indicators there. So I was just wondering what your views were about that and how we can support you to get us moving up the colours and such.
So we have actually achieved some of the deliverables on the silver. We have, so that's why I'm confident we'll get bronze and that we will get the silver. I think it'll take us about 18 months to get silver, but I'm hoping that we will achieve the bronze in 12 months. But you're right, Ian, I think a lot of the problem is around data, the quality of data and the data that we get in, to assess how we are progressing and how we are improving around this. And this is some of the work that is being done at regional level.
Thank you. Got Ruth and then Chris.
Just a quick question, and Claire sort of mentioned it about the questionnaire and the self-assessment. I was a bit disturbed to hear that only half the organisation completed it, and Claire suggested it might be because it was complex, although you managed to do it. Have you looked into why half the organisation or half the directorates didn't engage with it?
So some of the feedback that did come back was that it was felt that a lot of the questions were relevant to the corporate functions, and so it didn't feel relevant at place, and some of the other functions. But also there was a bit of resistance to kind of completing the self-assessment because of the language, the language in there, how that language was perceived.
Chris?
Yes, but just to conclude, Chair, one, I'd like to thank Thomasina for leading on this work. I think Thomasina's been in post since April of last year, so it's still relatively early work for us. And it is very much the start of the board's journey around this. As Thomasina said, I think the session that we have in terms of our development in February will help people to understand this and look at every decision that we make through an EDI lens. But we have got much work to do, and I think, whilst Thomasina said that we meet the criteria or are on our way to meet the criteria for bronze, absolutely support that decision. But it's about having a concerted and a sustained focus around this agenda that will get us through to silver. It isn't a one-off exercise.
Well said, Chris. And Graham?
Thank you, Chair. Thank you, Thomasina. As Thomasina's indicated, this is not just about our network for this staff group. We have networks for all of the staff groups that you might describe as having protected characteristics or being discriminated against. Every one of our staff networks will have an executive champion, and I am personally going to be the executive champion for the BAME staff network. I think that's important for two reasons. One, I think my personal leadership in this space will lend weight to and put more initiative behind the work that we need to do in this space. But I think secondly, if we can improve where there is discrimination and that discrimination is often visible, then actually that will help us get better in improving in those areas where we have discrimination and those protected characteristics are not visible. I've already had a meeting with Thomasina and a lady called Andrea who chairs our internal staff network in this space. And I have to say, I found Andrea one of the most engaging and enthusiastic individuals I've met who works for us. I think she's one of your team, isn't she, Anthony? Yes. Excellent. Turning now just to the primary care point, I think the primary care point is important for two reasons. So one, as Claire has said, so many people who work for the NHS work within a different employment model and work within primary care. And actually, it is primary care leaders who have come to us to say, we really like what the NHS in the North West has been doing in the BME space, the development of the anti-racist framework. How can we be involved? How can we use this to support all of our primary care employers? But I would turn that question round. My experience and my superficial evidence taking from primary care is that is a place where BAME people find it much more comfortable to gain employment and to gain opportunity, and therefore I think that we approach that not only to support them, but we approach this to see what we can learn from them as well. Thank you.
Thank you.
Thanks, Ed. Just two comments from me. Thomasina, just I haven't finished one. Two comments from me. One is it's really, really good to hear about the ambitions that we have for making a difference, not just within the ICB, but further afield into primary care. But when we look at budgets, we need to ensure that we match our promises with commitment. And so there's always going to be a prioritisation of the capacity that we can put in. So let's be, if we're realistic about our ambitions. Second point is one that Ruth was fishing for. Why did we have such a low rate? For some reason, I was copied into some of the emails from people who were they were objecting to completing the assessment, and principally they were objecting because they saw it as an affront to their values, and why would we think they were racist in any shape or form? I found it disappointing that we had that from some of our leaders, to be honest, and and that tells me about the lack of understanding and appreciation of the challenges that are faced amongst all protected characteristics, but on this one, this was race. So we have got a lot of work to do. It is a leadership question, and we will need to put our shoulders to the wheel to get this one up the hill that we're pushing up. So I know, Thomasin, you do brilliant work. We see each other reasonably regularly. I hear it firsthand, and also the challenges. So thank you very much for what you've done. Thank you.
Thank you.
Claire, constitutional changes?
Yep, thank you. So all integrated care boards must have a constitution that's approved by NHS England, published on the website and available to the public. And hopefully if you check our website, it's there. She says, fingers crossed, it is there. So our constitution came into effect on the 1st of July 2022 when we formally went live as an organisation. And other than some minor amendments which we've been instructed to make by NHS England, as all other ICBs have made following publication of the final Health and Social Care Act, we've actually not really made any further changes. So we've just recently reviewed it and proposed a number of changes which are outlined in 2.4 in the report. NHS England is also due to instruct further amendments following the provider selection regime regulations that came in earlier this month, and we've discussed that a couple of times already this morning. The amendments will be implemented following a receipt of texts, and that need to be included, so we won't have any choice in that. We've also had an early sight of the changes that NHS England are currently running through their legal team prior to releasing for integrated care boards to implement. So in addition to the text around provider selection regime, there is reference to the ICB having a named deputy chair and the removal of some redundant narrative in relation to statements around ICBs, such as sort of prior to establishment and when established. So really minor amendments, but something that we've all been asked to make. So we don't consider that any of the proposed amendments are substantial or significant enough to warrant engagement with the HCP or wider partners, but obviously it would welcome, through yourself, Chair, if the board agrees with that. And subject to approval, we'll proceed with the application for the variations to the Constitution to NHS England, and we'll also recommend that the board delegates responsibility to the Chief Exec to approve any further amendments to the Constitution with any feedback from NHS England. Thank you.
Thank you, Claire. So we're seeking your approval for those proposed amendments. Comments? Warren?
Just a typo on the, thank you very much for including voluntary community social enterprise.
Thanks, Warren. Gareth?
Sorry, just a very quick one to add to that. It also omits faith at various points as well, so that the reference that's used is inconsistent throughout.
Well spotted, thank you. Any other questions, comments? Reasonably straightforward, in line with our intention. People happy to approve it? Yes. Thank you. Chris, let's go to the terms of reference for the ICB Women's Services Committee.
Yeah, thank you, Chairman. So you'll remember in the November ICB board we brought the paper for the governance refresh, and the purpose of the paper today is to bring the refreshed terms of reference for the Women's Hospital Services Committee in Liverpool, which is a subcommittee of this board. The committee met last week, 17th of January, and approved the terms of reference. Some of the other, just highlight some of the things that happened at the committee was presentation from the Chief Executive from Liverpool Women's Hospital, who chairs the programme board. So he praised the committee about the approach to managing the clinical sustainability challenges, and presented some short-term measures, which was a specific focus around improving quality and safety in the short term. And that was including making some investments in additional staff and services on site at the Crown Street. So the paper just puts in the terms of reference. It also puts in details around the programme governance structure for the programme board and the committee. So it's to approve the terms of reference.
Thank you, Chris. Any questions or comments before I seek your permission to approve? No? Okay. Well, do people approve the terms of reference? Thank you. Rowan.
Thank you, colleagues. As I'm introducing this item, I'd be grateful if two colleagues of mine who are central to this, Professor Greg Irving and Professor Terry Jones, might come and join us at the guest speaker bit. So, IRIS, Integrated Research and Innovation System. It struck me from the very start of joining this organisation that if we have integrated care in a system, surely, and this is driven by my life in academia, we should be integrating research into our system as well. Good quality research benefits patients and generally improves the quality of care that is provided. There is some expectation that is set out for integrated care boards to facilitate and support research. We've endeavoured to go very much further than simply that in our ambition for this. We have a very complex ecosystem of research organisations and activities across Cheshire and Merseyside. And my sense has always been that these could be better facilitated, supported, coordinated, brought together. Why is it that patients might have to take 6 buses to get to a research appointment at a specialist hospital? Surely we should be delivering research close to home. Surely our research should be focused on the needs of our population to answer the questions and improve their outcomes. So it felt only right, and I'm grateful to both Terry and Greg who've joined, and the team sitting behind this and the work over the last 12 months, to create a system not purely of research, but the other eye is innovation. We've heard already today that we need to innovate if we are going to find solutions to some of the wicked problems that we face. And therefore pulling this together formally that reports directly to this board, because good quality research is so important, felt exactly the right thing to do. I'll let my colleagues take just a few moments to pull out some specific elements of this that the board would like to hear, and then we'll take any questions.
Thank you, Rowan. Thank you, Chair. So the principal ask of the board today is to approve the establishment of the Integrated Research and Innovation System and to approve some of the key aims and objectives of the proposed governance structure for IRIS, the Integrated Research and Innovation System. As Rowan has alluded to, the statutory obligation for ICBs to support research is actually written into the Health and Social Care Act, and there's a direct and explicit recommendation for that to be discussed at board level. Following on from that, there's been some specific guidance from NHS England on maximising the benefits of research, and that guidance is quite extensive, and what we're proposing here very much follows on and builds on from that guidance. As Rowan has indicated already, we're not looking to reinvent the wheel and replicate the work that's already gone on by a number of key stakeholders involved in the research and innovation economy across the system. Instead, we're looking to try and add value to some of that research activity that's currently taking place by principally being a convener and helping to prioritise some of that activity so that it meets the strategic aims and objectives of the ICB and serves the population that we're looking to support. In terms of the governance that we've proposed, so we're looking to have a Research and Innovation Committee, and I won't read all the details out of that, Chair, but it is detailed in the pack. And I think notably, there's quite an extensive steering group that will support and guide that Research and Innovation Committee as well. Again, I won't read out all the partners, but as you can see, we've consulted very widely in relation to that, be it the universities and the providers, the Innovation Agency North West Coast, public and patient involvement, the voluntary sector. We're already starting to see some of the benefits of that collaboration happening already. For example, we've received 3 tranches of REN funding, Research Engagement Network Development funding, multi-million-pound grants supporting some of that activity. We've seen considerable infrastructure that's come to Cheshire and Mersey and not necessarily gone elsewhere because of some of that collaboration that's already starting to happen. And we're in Wirral today, and we've already seen the benefits of that collaboration happening locally across the system. There's a Wirral Research Collaborative that's already started to expand its research activity and has won a number of national awards, and it's principally based on some of the activities that have started to happen out of some of those collaborations, and that's been supported. The functions of IRIS, again, we've listed those within the pack. I won't list them all, but some of the key ones that I think to draw your attention to is that convening of stakeholders. It's a really complex network of different organisations that we're looking to bring together, but I think the committee and the steering group are going to be uniquely placed to deliver on that. We're going to be key in terms of research and innovation planning and prioritising, so mapping to the joint forward plan, the Marmot objectives. In terms of meeting all of those things, we've got our eyes very much set on those strategic needs. As I said, prioritising. We've got some really unique tools within our community as well, such as the Cypher platform, and we're looking to capitalise on that as a key part of what we do. As I said, we're looking to expand research and innovation, and we're starting to see examples of that starting to happen already. Promoting evidence-based practice. I know there's been a paper come to the board previously about with the Constitution and the importance of evidence-based practice being built within that. So again, we'll look to support that. We look to harmonise and coordinate activities. A principal one as well is leveraging potential commercial activity as well. We've got some pretty big partners potentially in the Northwest and beyond, and we're looking at opportunities where we can capitalise on that as well, and help to provide a sustainable health service as well. So that was principally it, Chair. So the recommendations are as per the paper. I don't know if you want to add anything, Terry, or
it's okay. Thanks.
Thank you. I strongly welcome the commitment to develop research and innovation capability in Cheshire and Merseyside. As a strategic body, it's one of the key levers, if you like, to support transformational change. So absolutely welcome this focus. I have 3 questions. Typically, or often, innovation is focused on products, new products, not necessarily as much on process innovation, and yet we know the health and care system requires both. The other sort of issue that often comes up is the products are great, but they're not the things you would have prioritised as the urgent things that need to change the quality of care in the local system. So my question is, how will you connect the work of this group and be informed by the work of the Transformation Board and the 5-year forward plan to make sure that what we actually prioritise is focused on helping the system transform to a better model of care? That was the first question, making sure it's driven by what really the outcomes we want to achieve. Second question was, there's no business case attached to this, so I wasn't sure whether we were being asked to approve resources. I wasn't sure how you're going to manage all this work, and so I didn't want to agree this without knowing what the financial implication was. And thirdly, the governance proposal in the appendix is different to the governance proposal in the paper, so I just wanted to clarify which governance proposal we were endorsing. So those are my 3 points. Thank you.
Shall I take the first 2 points on that? Rowan, is that okay? Exactly the correct thinking around innovation. Innovation is a complex system in its own right that often starts with a gizmo and then you try and find a problem. We need to reverse that thinking completely and define the problems and then go and find the innovation to address those problems. Probably a conflict of interest that I should have stated beforehand. I'm also the Director of Research and Innovation for Luft, and that's exactly, so by far and away the biggest acute provider in the system, but that's exactly the thinking that we've addressed as part of that, is to identify the problem that's important for the organisation and then innovate to overcome that. There's a second or third part of that, is how do you measure the benefits of that innovation? Whatever that might actually be. So the thing we also have to think through in the system is how we measure outcome and output to show benefit, because otherwise it becomes a so what agenda. So I think that's the answer to that. Your second point, which I've now forgotten, was
financing, the business case?
Yeah, financing. So that's an important point. So as it stands at the moment, I think the conceptual thought about financing at the moment is the system holds the resource. So we're not, and a key part of this is not to duplicate what's going on into the system. It's to actually corral what's going on in the system and to augment and facilitate that so that you then create a whole that's greater than the sum of its parts. So as things stand at the moment, we have limited resource at ICB level, but at the moment, that's simply to coordinate, understand what's going on in the system, so that then we can strategize what the stakeholders of the system want by pulling some of those things together. So at the moment, we haven't asked for resource, but we did put the rider in that at some point in the future, we may well require resource.
And just to add, to be clear, both Greg and Terry are in posts as Associate Medical Directors in our Directorate. We've already got resources within our places, particularly Liverpool Place, who have all come together in order to support and manage this function. So that's why there is no specific ask for resource. In fact, we've been quite the opposite. We've already been awarded research grants as an integrated care system and are actively delivering research on funding that's been gained externally rather than asking internally. Finally, to pick up the piece on just making sure that all of our bits of that line up, I absolutely recognise that. We've picked that up, and indeed the final terms of reference will move back through this space as well subsequently.
To answer the question explicitly, it's as per the paper rather than the appendix. So yeah, we'll be taking guidance on that from the ICB, and it will follow as per the paper.
Yeah, I just had a couple of observations, and I think they were became more stark for me following Thomasina's presentation, that as part of ensuring sort of integration, and this is really exciting innovation, I think, to ensure that you do have that sense of equality and diversity at all levels of this work. So I'm just noticing in terms of the committee and the steering groups, just to ensure that that's embedded into the principles, and also that the language in and of itself is in that sense of DEI is really embedded into the language.
Yeah, completely accept those comments, and certainly with the certainly we're working with some of our key partners like the NHR ARC. They have a lot of activity in terms of like seldom heard voices and making sure other groups are represented, making sure inequalities are considered throughout all research activity. So we're very much amenable to that. So yeah, that's great.
Okay.
Thank you. Thanks for that. I agree. Research is really, really vital. On Wirral, you're right, there is a Wirral Research Collaborative led by some GPs and some other people. How linked in is that? You did mention before, is that what you're alluding to? And
yeah.
Is this similar across
well,
C&M?
I think this is a nice example of working within an ICB and a system, in that that the activity that's happened within Wirral, we meet regularly with the ICB research leadership team. In fact, we're meeting this afternoon. And some of that activity and particularly how those connections got established and how has that function worked. There's a really good opportunity to spread some of that activity across the system as well. I know certainly in our the place where I work clinically, those discussions have been I guess it's been a real catalyst of looking at what activities happened elsewhere and how that could be replicated across the system.
Fiona?
I'll be really quick. This is really positive. Thank you very much. I have been given a job ticket to think about the ICB's approach to continuous improvement, so it would be really good to have a conversation about how we join that up so that Iris isn't sitting over there somewhere, but it's an integral part of what we're doing.
I couldn't agree more than that. And can I make a more broader point as well? I also have a role in leading on the integration of research nationally as part of UKRD. And I think we in Cheshire and Merseyside have a huge opportunity to become an exemplar ICS, ICB here, to try and deliver some of these things that others can't or are not focusing on at the moment, and particularly around the inequalities aspects to this. It's the stuff that we should be focusing on, integrating this completely into our clinical services so that they're exactly the same to provide all those benefits that you've been talking about this morning. But I just take it further than that to say that we can be a national exemplar in some of these spaces as well, and we seek your approval to try and do just that.
Graham?
Chair, if I may, great place to be starting from. The kind of really powerful message I took from this is turning this from responding to who are out there as funders to coming at this from what are our population needs. And I think that's really fundamentally important, but also recognising that there will be a balance. So there'll be some things that are being done because out there is somebody who will fund it. I think the other thing is this point about not asking for any resources today. I think when you do come back at any point in time to ask about resources, we will want to see some substantial mapping of the use of existing resources. Because, for instance, you make reference to Cypher within here. You don't make reference to something called the secure data environment, but I know that there is work going on in those places. Things like Cypher have been funded by the ICB. Things like the SDE will be funded by NHS Digital nationally. It's really quite important that if we've got a researcher that is using assets that we have paid for this system, that we see what contribution is being made back for those assets. So I think the funding debate is a two-sided question. And then the final point I want to make, and these are future things, but I would think that we would also want to see some policy development in this space. And for instance, what is the IP policy? But I'm glad to see the AHSN referenced in here, because they should be our resident experts on that matter within our system. Thank you.
Thanks, Graham. So, I'll take to the board that what we're seeking here is the approval of the Integrated Research and Innovation System, along with a research subcommittee and a research steering committee. I think the terms of reference attached need to be further iterated. Okay, so people approving that, and then to approve the key aims and objectives and focus areas of the proposed governance structure for IRIS as detailed in the paper. It's good. But added on to that, I think, Rowan, Greg and Terry, is, I'm going to summarise it in this way. I think you need to set a timescale out for bringing back to this board your research strategy and then your research plan, which needs to be costed. Yep. Okay. Done. Thank you very much.
Thank you.
Good conversation. Chris, can we go to Freedom to Speak Up? And Vicky, is Vicky here?
Yeah, thank you, Chair. I'm going to invite Vicky Wilson, who's the Associate Director of Workforce and the ICB lead for Freedom to Speak Up, to update on the work that we've been doing in this area and to take you through the self-assessment which we are required to undertake by both NHS England and the National Guardian's Office. So I'll hand over to Vicky.
Thank you. So you'll be aware of Freedom to Speak Up and the role that plays in providing an alternative channel for workers to voice their suggestions, concerns or any other matter. NHS England requires that ICBs must ensure their own staff have access to routes for speaking up and all the associated arrangements with that. So establishing those arrangements has been a priority focus for us since the ICB's inception. We've made good progress with our plans, and you'll see from the report in the Action Plan Appendix 2. I'm not going to go through the detail of that, hopefully it's self-explanatory. We're required to complete the self-reflection tool, which has been completed, and that's included at Appendix 1. Now, that tool's helped us identify areas where we can further develop and enhance our FTSU arrangements, but also importantly, there's something about that wider cultural improvement. We're required to submit quarterly reports to the NGO on speaking up activity within the ICB, and we've done that. A significant point to note is that we don't actually have any speaking up in the ICB, so we don't have staff coming forward and using Freedom to Speak Up. And so we really need to ask ourselves why that is. So perhaps it's that there's nothing for people that they want to raise concerns about or speak up about. Perhaps they don't know. perhaps they don't think we'll take action, or perhaps worse, they think there might be some sort of negative consequence. You'll note from the action plan that we're undertaking a survey and some focus groups to explore that with staff. And whilst the survey is actually live currently, it hasn't yet closed, I am pleased to say that having reviewed the responses so far, and we've had over about 130 responses in the first week or so that it's been out, it isn't the case that we've got large numbers of people saying, I don't want to use this because I don't think it would work. We've got people saying, actually, I'd speak to my manager, that would be my first port of call, I'd try and resolve it locally. So that's really positive. That said, there are a small number of responses where people do raise those concerns and say, I'm not sure that this is a process that I would have confidence in, either through to kind of previous experiences, other people's experiences, or just perceptions about how the organisational culture might be. So kind of getting to understand that and work with staff to explore how we can shift those perceptions is going to be something that's really important. And that's where this then becomes more about the organisational culture than the actual freedom to speak up process itself. A potential measure for freedom to speak up success is that actually we don't need that process because everybody just through normal business goes to people locally and voices the concerns or suggestions that they may have. I think it's fair to say that, you know, we are a way off that level of maturity and likely would always need some sort of alternative route for people to use as a safe option. A priority for us this year is to really then embed that kind of culture where people feel confident that they can speak up within our organisation. And that will require leaders and the board, the wider senior leadership, to embrace speaking up activity and actively role model those behaviours. We need to recognise, and it's been referred to already, where we are on our journey as an organisation, but we are approaching kind of 2 years, so we need to kind of think about what that means for us in this context. I think if we asked ourselves to think of an example of how we as individual leaders have demonstrated that we welcome speaking up, we encourage it, we want our staff to speak up, we want them to see from us that we would take action. If we said, when did we last really do something to show our staff that we're ready to listen, to learn and to take action, I think that's something that our honest reflection would have to be that we perhaps haven't done that enough. And I think it you know, links a bit to the anti-racist framework, that it's not enough to just say, well, I would be happy if somebody came and spoke to me, and I wouldn't do that myself. We need to be really active in that space. Just picking up on Erica's point earlier, one of the actions that we've got planned is the development of a staff experience dashboard. And that's part of the overall workforce dashboard to help us understand what key indicators we can look at to build that picture of what it's like to work here and what it feels like in the organisation, not just some of the hard measures. Also, as part of our Freedom to Speak Up summit, which Erica is the non-executive lead for FTSU chairs, we're looking at how we've got other organisational data that we can triangulate, and what, if we look at that, it would tell us about the organisation and what it perhaps hints at that staff might not be telling us. Similarly, picking up on the point that Anne made earlier, I think the best thing we can do for our staff and their well-being is take away the pressures that they feel, take away the things that cause them stress. And we were having a conversation just this week in relation to how we support staff and well-being. But whilst we can do a lot of those other things, if we don't get the basics right, none of that really matters. It won't have the impact if we can't get the kind of fundamentals right. That said, I think as Chris referred to in her update, it's really positive that we've got the Staff Engagement Forum and other staff networks that are working really closely with us to help us understand what it actually is that matters to staff, so that we're targeting our efforts in the right area to do the things that will have the biggest impact. I think as Thomasina said, we need to look at how we develop a culture where people feel included, valued, and really importantly, psychologically safe. People won't speak up if they fear what might happen as a consequence. It's important to note, not only for speaking up, but more fundamentally, and I think Ian raised the point about data, even just to share people's data about their protected characteristics, they need to understand why we would want that and feel confident that we're going to do something positive with it. So it really is important to everything we do in this area. You'll note from the action plan that we've got some planned time within our Senior Leadership Forum coming up, and we've also planned some board development time to kind of look at this further, not only around FTSU, but just the wider kind of cultural piece. And as Graham and Raj have both said, role modelling of leadership in this space is going to be really important. Culture won't happen just because, you know, we say something. It's got to be about how we act and what we do. We're in the process of recruiting a dedicated guardian, which will give us much greater capacity to this agenda than we've been able to focus before. So I'm really confident that that will help us progress this at pace. I think, as I said, we've made good progress, but we've been limited by the capacity that we've been able to dedicate to this. And you'll note again that the actions that we've got planned speak to the risks identified in the paper, particularly around that capacity, but also around the levels of speaking up. So I'd welcome a steer on how frequently you would want to be updated around Freedom to Speak Up, noting that the updates also go to People Committee and Audit Committee. I think that's probably everything that I wanted to say, so I'll pause there, but happy to take questions.
Thanks, Vicky. Well presented. Can I seek any questions or comments? Erica?
Yeah, I suppose just a quick comment from me, really. You know, it was really good and covered all the areas. I think we just need to take away that awareness. You know, I've talked about it earlier this morning in these papers. One of the things I reflected on was in the CEO report. You know, we talked about the industrial action. There were no significant areas of concern relating to industrial action itself. Is that true around freedom to speak up? It could be. It's just, I think there needs to be more triggers in our mind to actually think, are we getting the data? Because it's very difficult to get the data on this. But are there any triggers? You know, what we're trying to work through are what are the triggers that will give us a clue that something may be, you know, not as it should be, and then what are the gaps? So I just welcome everyone just to kind of have a little, that word lens on everything that we're talking about. So thank you.
Really important point. Laura, just because I can see you rather than Mark. I would guess that there could be more issues at place level closer to the patient, which could result in our staff wanting to freedom to speak up. Firstly, do you think that's more true? And if so, what do you think we should be doing to make sure that there is that supportive environment that Vicky's?
Yeah, and I would agree with your suggestions about looking at those wider, you know, measures. But I feel it, you know, personally, how do we put the emphasis on creating the culture where we're hearing all the time what people are saying? I'm hoping that, you know, the work we're going to do around responding to the staff survey will help us to do that, so people feel safe to voice it. Doesn't mean we can address every issue that they are saying, but I think you're right. I think at place level we have the opportunity to hear about the things that people feel are impacting on patient care, that they may feel are being ignored. So it's really important that they can articulate that as well as their own personal working situation and day-to-day operation. So it's building that culture, as you say, isn't it, and supportive and responding and showing that we're responding when people do speak up, even if they don't see it as formally as this process. Thank you.
Thanks, Laura. Really helpful. So if we can take us to the recommendations, it's essentially to note and to endorse, but deciding how often it comes to this board, it has to come at least annually, I've thought, but we need to think through, I think, how it comes, clearly through the appropriate subcommittee, but thinking through the other indicators that we have around this field that enable us to see a holistic picture, perhaps as part of the HR report. That would be my initial thought, Vicky, but you guys, the experts, that's come up with something that really gives us intelligence around this. And lastly, I think you made the important point about us role modelling. So do say to us and the board members, what is it you think we should be doing more of to enable the right culture to be developed around this? Yeah. Okay, thank you. Yep, are we happy to move on? Thanks, Vicky. Okay, I have not been notified of any other business. Graham, I don't think there's anything else. No. Close of the meeting. Thank you very much. Apologies for running over. It's been a good, productive meeting. So it's now 10 to 1, and we've got another meeting after this. 20 minutes?